Hello? Did I do it? It's been a long time since I've messed with something like this. So it's a little confusing. How do I put the chat in here? How do I delete this? Remember to live chat and to guard your policy. Okay, thank you. It's great. How do I do this? Okay, so that's set up. You're gonna have to give me a second while I try to make this work. It's very confusing. Oh man, I wish I remembered how to do all this. Let's see. How do I pop out the chat? Pop out chat. Can I just put it right here? How do I put the interface of the chat in the stream? Computer, show me how to do that. Okay, close it. That's okay. I think I remember how to do this. Live chat. I'll call it this. And then to enable it, I'll take this chat. I will copy the URL. That kind of worked. I don't want it to be this big. How do I put it to where it's not this big? I don't know. I also don't even know if I set this up right. How do I even see the chat? Hello, is this working? Let me see. Amateur medicine. Click. Oh my gosh, there's an ad. Don't worry, we'll get this going pretty soon. I'm an expert. Skip ad. Now, how do I make it on OBS so that way it doesn't have this crappy looking thing? OBS, how to have live chat. Get the chat URL, add source in OBS, customize appearance. You can customize it via the CSS if supported. I would love to customize it. Yes, sir. That's what I like to see. Give me a second. Filter. Make it not look like garbage. Add effect. Make it not look stupid. You know what I can do that I've learned as an adult? If you have an issue with this, go to ChatGPT, take a photo of it, how to make live chat look less invasive, such as the names and text only. That's a little EMS tips and trick for you. Looks like you're using the default Twitch chat dog, blah, blah, blah. Go to stream elements. Oh, no. Oh, no. I don't have the time for this. Crop the existing widget. I like that. Hold Alt, options on Mac. Drag the edges on the chat source. Oh my gosh. ChatGPT is a genius. That looks so much better. That's why we use ChatGPT for everything. We'll just put it here for now. Let me see how I can do this too. Congratulations on your nursing. I got my NREMT cert, but next goal is the emergency room tech and then nursing. You have some great content that helped me pass the NREMT. Joshua, I'm so happy. And also thank you, undisputed 1291. Buddy, I'm so glad to hear that. I think you're going to do great in the emergency room. That's fantastic. Or whenever you get to the emergency room, they will hire, they won't just hire anybody, but like throwing your name in helps. And depending on how much you work, they may even be able to pay for some of your education. So I think that's a phenomenal idea, what you're doing. Let's see here. Okay, we're probably going to start in like a minute. I'm super excited about this. There is a game out there called Ambulance Life, a Paramedic Simulator. It's very tough to get started with, and it's kind of I had to turn down the settings all the way. But this is a great way to see a bunch of different scenarios. And I'm recording it. I'm going to chop it up for YouTube later for an actual, what's it called? I'm going to chop it up later to make actual videos from it. But I thought it'd be fun to maybe even stream it too. So let me see how I can do this. Copy. Where's Discord at? Hey, I work as an ER tech. First healthcare job after passing the NREMT last December. Congrats on earning your cert. Yes, congratulations. We're very happy for you. Let me see how I do this. And then I can put at everyone. Hop in if you want to see some live scenarios. Really funny. Okay, and I need to intro myself as if I'm doing this for YouTube, right? Hey everyone, my name is Mario Martinez, and this is Amateur Medicine. So today I decided to do a video over this game that's on Steam. It's called Ambulance Life. It's a paramedic simulator. The controls are a little goofy, but what's really great about it is that you can do different scenarios and kind of work your skills. There are some things that it's good with, some things that it's not good with, but I'm going to give you my opinion as far as somebody who is a paramedic, as a firefighter, as an EMS instructor, and as somebody who just recently became an RN. So I do have some experience with this. Last year I got the most calls for the fire department that I work at, and honestly I'm like lead for 99% of them. So I do have some experience. I'll probably make some mistakes along the way, but I think that's part of the fun in any game, right? Unfortunately for this game, you have to unlock certain skills. I did play about an hour or two just to kind of get my feet wet, so I wouldn't come in as somebody who doesn't know what they're doing, because again, the controls are really clunky. But we'll kind of go through it and then move from there. So I'm really excited. I may make some mistakes again. I apologize for that. There ain't nothing I can do about that. Let me make sure this is good real quick. And then we'll hop right in. You guys are getting the live, unfiltered version, but I think that's okay. Let's see here. Hopefully whenever I record, I don't know if it's going to actually show the chat. I need to figure out a better way to put that in there. And it may be blocking too much of the screen. We're going to have to see. Anyway, we're doing a new game. No for your career slots. That's okay. We're going to delete Natalie here. Select. I select this one. No. I want to delete. Give me a second. I have to exit out of this mission or this campaign, I guess, and then pop in a new one. Come on, you. No, we're not being Natalie. New game. All your career slots are taken. Choose. Okay, there we go. Delete. Deleter. Okay. We have a couple different choices as far as paramedic characters go. We've got Elijah, Mateo, Liam, Jill, Jeremy, Natalie, and Angela. Ooh, Angela's a little rough. Her hair's a little... They got some wild hairstyles. Liam's a little rough too here. I don't care for this at all. Not very professional. Mateo, we're picking you. His name is Mateo Hernandez. My name is Mario Martinez. You know, we vibe on a similar level. He's 41. He's 40. I'm 31. So I think we're gonna sync up really well. The intro to this game is super loud, and I apologize. Just let me know if you have any issues with the audio later. All right, we're going in. Display nudity? No, we cannot do that. We have to make it YouTube friendly, but I'm very excited for the scenarios it's gonna throw in. Also, let me know if I'm echoing too much.
Welcome to San Pelicano. This place is home to some of the world's finest EMTs.
Beautiful.
And you are about to join us. Let's get started. You've been assigned to downtown. It's busy and chaotic.
Busy and chaotic?
Where we
That's what I
excel.
love to hear.
Your job?
That's where I
respond
thrive
to
in.
emergency calls all over the district.
That's a crazy scenario.
Stabilize patients
That's
in
crazy
need
that they're
and
not using a
transport them
backboard or
safely
C-collar,
to a
but
nearby
you know what?
hospital. Remember,
That's
it's not
okay
just
for this
about
type of
speed.
game.
It's about making the right
Also,
decisions under pressure.
accessing an
Lives
IV like
depend
that,
on
that's a
it.
little interesting.
The faster you learn,
But that's
the
okay.
sooner you'll get the critical cases. Stay sharp and always be ready. Now get out there and make a difference. Show San
course.
Pelicano what you are made of.
This is basically GTA
We're
6,
counting on you.
but more so as the supporting characters.
Ah, here's our new paramedic. It's
There's
nice
Miss
to meet
Johnson.
you. I'll be overseeing your training today. Hop in the ambulance, and we'll wait for our first assignment from dispatch.
Of course, Miss Johnson. Let's go.
If you ever get lost, check your map. It always shows you where the ambulance is located.
All right, let's get in, Miss Johnson.
Dispatch calling ambulance 152. You are
We're
needed at the scene of an
152.
accident.
Okay. We're needed at an accident.
One person
collapsed in a parking lot in downtown Pelican.
Over.
Oh my gosh. We're going lights and
152,
sirens.
Roger. Heading out.
Let's go, Miss Johnson.
We have
It's
received
weird
our
how
first
she
call.
gets to be lead
Don't worry.
and I'm
I
also
will
driver,
assist you every step
but
of the
I'm
way.
lead? Or
You
is she
can
sitting
check
in the
out
lead
full
spot?
version of the
Normally,
map if you want to
let's
see.
pause it. So just as an initial heads up, if you're actually riding in a box, I guess I don't have to pause. If you're lead or the main one in charge of the call, you're going to sit in the passenger side. And the driver, if you're running an ALS unit, is usually going to be an EMT-B. Sometimes it's an AMT, or sometimes it's another medic if you're riding dual medic. So if I'm in charge of this call, I would be sitting on the right side. I would not be driving, but I guess they just do whatever in San Peliano. Okay, there's a map to the call. Fantastic. Let's go. We're going what's called code 3. I need to change one setting also. So there's a game setting that basically if you hit too many pedestrians, you lose. I'm not doing that. I'm going to hit people. I'm also potentially going to total my car. Yes, I know how to turn on the sirens already.
The location marked on your map. Use the siren as needed.
Just because, you know, it's a video game. You know, normally how would I approach this in real life? I would slow down to the stop sign or to the stoplight. I would wait, check both sides. I guess just here I would check one side. If I'm good, then I would go ahead and drive. As a video game, we're not doing that. That just ain't happening. Okay, and then the fastest you can usually go is 10 miles over the speed limit. Again, this is kind of nice how they're kind of moving, but this is actually pretty realistic where sometimes they just don't pull over or they just don't get out of the way. That's fine, I guess. All right, and as you pull up to the scene, you normally want to turn off your sirens just as you're pulling in, right?
We've arrived.
Okay, so we've got our first patient, and again, what's really weird about this game is you have to unlock protocols later on. So I can't normally do what I would like to do. But I think that's okay. All right, let's go see what's going on in San Piliano. Let me check one thing also. Okay. So we got our first patient here. They're sitting down next to a car.
Looks like this is our patient.
They've got some
They
things
appear to be conscious.
that have fallen down.
Before we begin treatment, we should ask the patient a set
So we
of
need to see
relevant
what's going on
questions
here.
about their person and medical conditions.
What a great idea. The patient's name is Jan
This is
Doe.
called anamnesis.
Okay.
Try to retrieve as much information as possible. The more we know, the better we can help.
You're right, Miss Johnson. Let's find out what's going on here.
My whole body is aching.
Her whole body's aching right now. Let's see what happened.
I suddenly heard this ringing noise in my ears and
She has a ringing noise in her
felt
ear.
dizzy. I sat down.
She
and
fell
called
down
for
and is
help.
asking for help. So what's relevant about this? We have a patient who sat down whenever they had a ringing noise. So we know that there's no actual trauma that occurred. We know that we don't have to worry about potential C-collar or backboard, just going off of her general first impression. She's talking to us and able to talk in complete sentences. We still need to further assess potential her gait, seeing how steady it is. If we need to consider something like possible stroke-like symptoms. But this is good so
I
far.
suddenly heard this ringing noise in my
Okay,
ears.
I
and
already know that.
felt
Take a moment to
dizzy.
further
I sat
inspect
down
the
and
patient.
called for
Okay,
help.
we need
You
to
might
further
find some more
inspect the
evidence
patient,
while
see what's
inspecting
going
different
on.
body parts.
So let's go into our Batman mode, our focus mode. Let's take a look here. She seems restless. Maybe it's a little hot outside. Okay, and the game basically makes you scan all these little dots. Beautiful.
We've
Okay, it
received
looks
new
confused.
information about the patient.
If
I
she's
already made
confused,
a
then we
note
need to worry
inside the
about
patient's
C-spine
protocol.
precautions. But that's okay.
This is
Okay.
where we collect all relevant information
take a
about
look
the
at other
patient
stuff.
and mark down newly discovered pieces of evidence. Take a look at it now.
Of course. Thank you, Miss Johnson. Let's access the patient protocols. Now, I disagree with the game as far as the categories and the interim diagnosis go. But I'll just play along for now.
These are the pieces of evidence you have discovered during an anamnesis.
Okay, so they're
and
saying it's a
inspection.
neuropsychiatric episode. We don't really know
For
too
each
well.
patient, you will have to
There
make
are
an
some
informed
other
assessment
determining
on
factors for what
could
can be
the
going on, and she
underlying
has
cause
extreme stress.
responsible for the emergency
She's
based on the
restless,
collected evidence.
stressed, nauseous. So if she's nauseous, as a paramedic, what would I consider?
This patient
I can
does not
administer
appear
something
to
like
be in any
ondansetron.
immediate danger.
Okay, come on, Miss
Choose a
Johnson, I get
category
it
and
already.
an interim diagnosis that fits the evidence.
Thank you. Thank you, Miss Johnson.
Your interim diagnosis can always be adjusted during treatment.
Of course.
Let's go back to our patient now. Good. Let's put the patient on the stretcher and continue
I would
treatment
honestly
inside
do
the
something
ambulance.
different from what Miss Johnson's recommending. So when we have an initial patient that's on the floor like this, as I'm asking questions, what would really help is if my partner would come in and assess a baseline set of vitals. They like to assess vitals in the ambulance. I'm not a big fan of that. I like to assess vitals on my patient before I move them at all, because they could have orthostatic hypotension. They could have it to wherever they stand. They get a bit more lightheaded, and their blood pressure tanks. I want to see what their baseline vitals are like whenever I first see them on scene. But that's okay. Let's go ahead and get the stretcher. And the stretcher controls are a little clunky in this game. That's okay. Let's get up here.
First, we need to assess the patient's vitals in more detail.
Of course.
This can only be done inside the ambulance.
What a great idea. Okay, now I need to get into the ambulance.
For now, there are 3 key vitals we should worry about.
We should worry about blood
Oxygen
sugar also,
saturation,
but we can't check
heart
it right
rate,
now.
and blood pressure.
Okay. Blood sugar must be measured repeatedly.
To measure both
I would do it
oxygen
one time.
saturation and heart
personally.
rate, attach the oximeter's clip on the patient's finger.
Okay.
Diagnostic tools will then provide you with live readouts of the patient's vitals.
All right, let me access my treatment. Okay, thank you. Okay. Okay. So what do I have access to here? I can put a pulse ox on a patient. I can put it on their, not their left forearm. I would do it on their finger. But that's okay that it says that.
Next up, try attaching the blood pressure cuffs to the patient's upper arm. It will
What a
provide
great
you with
idea.
information about the patient's blood pressure.
And I would check blood pressure on the opposite arm. That way it doesn't interfere with the pulse ox reading. We don't need to take off a patient's shirt whenever we're assessing this. I have to study my EMT
Vitals
notes
are
again, but I
displayed in
do
more
have to
detail
assess
inside
their
the
and the
patient
status
protocol.
first as
Feel
I'm
free to
walking up
take
to
a
them.
look.
This is perfect for you under defeated, undisputed. Okay? So right now we have some readings. Okay? We have a blood pressure, a BP at 123/82. It's completely normal. I'm fine with that. We have a heart rate at 91 beats per minute. That's normal. It's less than 100 beats per minute and greater than 60, so that's good. Their SpO2 or their oxygen is at 100% SpO2. Fantastic. Some texts will say 94 to 99 or 95 to 99% is normal. If it's 100% SpO2, perfectly fine. Their temperature is at 98.6 degrees Fahrenheit. Looks really good. They're not reading a blood sugar. If a patient felt dizzy or felt weak and then sat down by the car, I really think you should check their blood sugar, but I can't at this time with this current game. Okay? And I have a 33-year-old female patient, right? Again, she looks confused. That is unsettling. I would normally ask if they're A-No times 4, right? Their person, place, time, and event to see more so what's going on. What do you mean by they look confused? And kind of determine if they need a possible CT scan. You're finished assessing the patient. I disagree, but in the tutorial, there's nothing I can do about that. Again, this patient doesn't need to be uncovered
Temperature
like
is going
this if
back
I'm
up
checking
to
their blood
normal
pressure.
levels.
If anything, I would put, if I did take off their shirt, I would reapply their shirt, even if it's exteriorly, to give the patient some modesty. They don't need to be exposed like this. Okay? All right, let's get out of here. And for a patient like this, if we're transporting them, we don't need to go code 3. They're in a stable state. So we can go code 1, and we should be fine.
All vitals seem to be within their normal
Let's
range.
get out of here.
But this patient is clearly unwell. Let's take this one to the nearest hospital, just to be safe.
Okay, so normally would you be driving
I will
like this?
monitor
No,
the patient during
but this is a
transport,
video game.
while you
I
drive
am
us
going to
the
kind
closest
of
hospital.
drive
Seems to
pretty
be safe,
haphazardly.
So no need to rush.
It's fine, they're fine. As a medic nurse, would you be comfortable making this a BLS call, handling it to your EMT? That's such a great question, Grape. That's exactly the kind of commentary I'm looking for. So, personally, no. If the patient feels confused, if they felt weak, dizzy, what's something I would do? I would do a 4-lead or a 12-lead EKG. And if you do an ALS medical interpretation of an EKG, then technically it's an ALS call, and I would not hand it off to my EMT. Some services, I could see them arguing, oh, it's not a big deal, but I like to be really thorough with my investigation. I don't know if she's possibly feeling weak or the ringing in her ears is a byproduct of a possible STEMI or ST elevation causing a myocardial infarction, or some people would call it a heart attack. So because that's the case, I would not hand this off to an EMT-B. But that's a beautiful question. Really good thinking there. Again, also, I wouldn't be driving like this. This is a video game. I mean, what am I supposed to do here? I'm not gonna wait through traffic and wait through it. And this is going code 1 to the hospital. If I was doing a radio report, my patient's like 33 years old. I would do something like, I'm just going to say Medic 72 for this. I'm used to that. I would say Medic 72 to, I'll just say Spawn Shoreline because I'm used to that. Medic 72 to Spawn Shoreline. Spawn Shoreline, go ahead. Medic 72, I'm coming in with a 33-year-old female patient who is currently A-No times 4. Patient advises that she's been feeling weak and dizzy, a little bit nauseous as well for the past, I'll just say like 30 minutes. Patient advises that, our patient, I guess that's fine, right? Let me pull over and actually do this. Okay. Medic 72 to sponsor line. Medic 72, go ahead. Medic 72, I'm coming in code 1 with a 33-year-old female patient. Patient's GCS is a 15 at this time. Advises that she's been feeling weak, dizzy, nauseous, and has ringing in her ears. Patient's last BP was 133/72. I'm just guessing here, right? I have to look at my notes. Heart rate's at 96 beats per minute, setting at 100% SpO2. ETA to your facility in approximately 5 minutes. And then normally I would have like an IV established too. It's kind of a choppy report. Oh, I should also mention the temperature at 98.8. But that's okay. Should I consider AEIOU tips for the altered level of consciousness or newly onset confusion? Yeah, you could, right? But they said this patient appears confused. At least from my initial assessment, I wouldn't say that. We should also be looking at their pupils, right? So we'd be worried about something like, are they suffering from hypoglycemia? So we should be checking their blood sugar. We should be worried about their pupils. Maybe this is the effect of an opioid, especially as you get older. Once we go through like sample or signs and symptoms, allergies, past medical history, medications, last oral intake, and, let me end this call here. And the event, then we need to consider like, hey, maybe they're on some type of medication that could be making them feel this way, and maybe we need to go about it in a certain way. Let me answer a phone call real quick. But that's a great point.
We've arrived.
Paul. Let's unload this patient. Hey, sweetheart. Hey, I'm currently doing a live stream right now.
Let me see.
All right, love you.
We take over from here.
We'll talk
Nice
about
job.
it once we're home.
This
But I
concludes our
appreciate it.
first
Thank
call
you.
out together. If you need a reminder on anything, you can always check your
But great
All
question.
relevant information
I don't really
can be
use
found there.
AEIOU tips too much, but I think that that's a great point that you brought up, Paul. All right, how do I end the shift? End the shift immediately. We got an A. We're looking for an S. All right. This game has a lot of meat to it. So we've accessed a couple of things. We have access to car crash call out, stress attack call out, 15-minute shift, bandage, lorazepam, which I think is kind of weird to have access to lorazepam, also known as Ativan, in an EMS service. I think that's more so a hospital medication, but it's interesting that it's available. Neck brace, oxygen mask, stethoscope, a thermostat, ketamine, which is a pain medication you can use as a paramedic. It can cause hallucinations, and you should be really careful if you administer it to thin, elderly female patients. But we also have access to an IV 22 gauge. This is worthless. This is for babies, but you know what? That's okay. Some paramedics would argue, or EMS providers would argue, 22 gauge is better than nothing. Brother, if you come into this and you don't have a baby patient with a 22 gauge, the ER staff is going to look at you goofy, right? We do 18 gauges, we do 20 gauges. If they need a 22 gauge, if you can hold off, wait till you get to the hospital, and they can do an ultrasound guided IV. We don't need to be establishing this in the field. 22 gauge in the forehead, fantastic, grape. 22 gauge anywhere is just so goofy. And just in case anyone doesn't know what he's saying, we only establish IVs in the upper arms, the lower arms. We prefer to go to the hand and work our way up. Same thing for the left hand. We prefer to do the left hand, then the left forearm, then the left AC. We don't really go higher than that. You can consider an EJ, but that's for extreme scenarios, or on the side of the neck. But besides that, we don't do any IVs in the lower extremities or in the feet, in the legs, because those areas are considered really dirty. Although some could argue against it. I'm on the forefront of, if anything, if I really need to establish fluids on a patient, I'll go with an IO or an intraosseous where we drill into their bone. I'm not going to screw around with trying to access a line in the feet, and then they end up being diabetic, and then they end up with, let's say, like some type of systemic infection because of what I wanted to do. Okay, we have three options here. We have regular shift. We have a training panic attack or training venous bleeding. I'm on the mindset of just going to regular shift. What do you guys think? I'll poll it. Start a poll. Ask a question. Which should we select? We're going to put regular shift. We're going to do training panic attack, which I'm not too interested in, or training venous bleed. We're going to put a poll up here. You guys can vote for it. Already we have somebody saying to go for the venous bleeding. That's interesting. Bosnian 2967. I'm not against that mindset, but let's see. So what do you guys think we should do? We're seeing 100% vote for a regular shift. 70 a regular shift, 72-hour overtime shift. What a yeah, that's a classic. I'm more of a 48 hours, but you know, if you're rocking 72s, especially if it's IFTs or interfacility transports, that's tough. That's very tough. Ah, 72-hour, depending on the service that you're in, can either be really chill or it can be a nightmare. Okay, we have our votes. Bosnian, I respect what you're saying here. We'll do a regular shift, and then we may hop over to venous bleeding afterwards. That'll just be number 2. I'm good with these results, though. Okay. This is where the game gets fun, right? This shift offers you the regular EMT experience, responding to multiple emergencies and treating patients with various conditions. Key attributes: patients may die if not or incorrectly treated, and hitting pedestrians or crashing the ambulance causes a game over. I've already changed the settings. That's not the case for us. Some things to note, guys, or to preface. In this game, I've done like 1 or 2. They'll have like triaging for patients, and they'll have multiple patients. Okay, the thing about this game is you don't get a call-in backup, and you have to pick the most critical patient and go with that. So you're basically just leaving the rest of your patients to die. Okay, that's not what happens in real life, and I'll explain it whenever we get on a scene with like that. But it's very goofy how this game works. Tips for new paramedics: sometimes you can find out what happened by asking a witness. That's a great tip, especially if it's an unconscious patient. Am I still with Miss Johnson? I am. Oh my gosh, she's like oh, she's not balding. That's fine. That doesn't matter. Mr. Mailman! Oh my gosh, so good to see you, buddy. I remember you. Buddy, Mr. Mailman, just letting you know, I am a nurse now. A male nurse. I got my RN license. All right, let's see this call.
Ambulance 152, we have an urgent situation.
Urgent situation, urgent situation.
The accident occurred near a public
It's in a public parking lot.
A car
collided with the bike,
resulting in serious injuries
for the rider of the
They
bike.
are in need of immediate medical assistance.
Of course.
The location is being sent to you at this moment.
Of course. Okay, so right off the back, we have a call for a patient who is hit by another vehicle while they're riding a bike. So I'm worried about the patient, and I'm also worried about the person who hit the bike too, or the person who hit the bicyclist also. At this time, as I'm heading to this call, what would I be thinking about? I'd be requesting additional resources. I'd be requesting an engine company, and I'd also be requesting a second medic unit, because they're not going to want to go in that, both go in the same ambulance together. If it was up to them. Thoughts on bolus versus IV push, regardless of service protocols? It depends on the medication. It's a great question, great. It depends on the medication and what we're trying to achieve, right? If I'm administering, like, let's say morphine or something as a pain medication for a paramedic, I've got no problem with that. With an IV push, I'll just go slow. And if I do 2 minutes for my push, then I'm also doing 2 minutes for my saline push. But if I have like normal saline, I'm just going to hang it and do a bolus of it. I'll just let it flow. Not a big deal. Congrats. I got 1 more year in nursing school. Congratulations, Mr. Mailman. There's some things you want to know on the NCLEX. You know what? If you hop in the Discord and message me, I'll tell you all about it. But the NCLEX is literally just like the NREMT-P or the NREMT in general. It's an adaptive test, and it's really hard. but I would just recommend studying a lot. I'd recommend focusing on mental health and going from there. Joshua, what made you start this channel? I'll talk to you while I'm driving. So the reason why I wanted to start this channel is because I think that medicine, just in general, people are too uptight about talking about medicine. They're too focused on not being like, hey, you know what? I made a mistake. Or I want to talk about something where I think I made a mistake. And I think that they take themselves too critically just in general. And I think that you should have a place where you can say like, hey, I'm unsure about this call. Or, hey, I don't know anything about X topic. Like, let's say OBGYN. And then if you've been a medic for like a year or two and you've gotten really rusty, some other people may say something like, oh, you know, you shouldn't be a medic anymore, blah, blah, because you don't know about this topic and this topic. But I want to create an environment where you're able to have, let's say you're first onto the job, or 5 years or 10 years, and you feel like, you know what, I'm actually really bad at this topic, and you have a safe environment to talk about that and kind of communicate it. I also think that EMS education in general, it's no matter how you get taught it in 2 weeks, 4 weeks, 2 months, 3 months as an EMT-B alone, it's not enough time. And you should be able to go up to somebody who's had years of experience and say, you know what, I'm about to finish my program and I don't know anything about 911. I don't know anything at all. I feel like a phony. And instead of being assaulted verbally by somebody, you should be able to have an instructor say, hey, I've been there before and let me help you catch you up to speed. And that's what I do with students all the time in real life. And that's what I try to create for an environment for EMS in general. Like, I understand what it feels like to have like imposter syndrome, and I've gone through it to where I used to be a really bad EMT-B and where I feel like I'm a really competent medic. I think I'm a really strong medic at this time, but I still make mistakes, and we should be able to make mistakes and talk about it in a non-hostile environment. So that's more or less why I started the channel, and just to promote medical education in general. I think all of it's super fun. I love all of it. Okay, so we're going to triage these patients. I'm going to try to do my best job at it. Gotta go. I have a summer class right now, but good to see you again. Good to see you, buddy. And Mr. Mailman, you can always join the Discord at any time and ask me about the NCLEX and things like that, and I'll try to do my best at it. Okay, so we're approaching the scene. And what do we have? Okay, there's a car flipped. Oh, okay. There's cars that are flipped over. This is an evolving scene. This is a nightmare already, but you know what? As a EMS provider, we're going to do the best that we can. Okay, so if I was showing up on scene as an actual provider, and I'll say I'm Medic 72, I'll tell dispatch Medic 72 I'm on scene. And then I'm going to take a look around, right? I've got one vehicle that's involved, one person on the floor, one vehicle that's overturned, just right off the back. I have 5 vehicles involved. Okay. 6 vehicles involved, 7, 8 vehicles involved. Nightmare. Right off the back, I'm going to say Medic 72 to oncoming units. Currently, I have 8 vehicles involved. Dispatch, go ahead and send off another 6 medical units if possible. And let's go ahead and send in another 2 engines. We'll continue from there. And we'll see what assistance we have. If we work with Halo, then we may need to do a Medic 72, go ahead and start prepping Halo, right? And then I'm going to show up on scene. I'm going to start triaging my patients. We'll go right from here. If you actually have this big of a scenario, what you do is you go up to the sidewalk, right? I know I have this patient sitting here. I am going to be jogging, by the way. I'm going to go up to a secure area such as this, and I'm going to yell out loud. I'm going to say, anyone who can walk, come to my voice right now. Anyone who's stable enough to walk, you get a green tag. You get a green tag. You get a green tag. This is the beginning of start triage, right? This is a nightmare scenario for one medic alone, which is why I like this game. Okay, we're going to start by assessing. We got one patient on the floor. It looks like they're bleeding out. What's going on, miss?
In my left upper
Pain
leg.
in her left upper leg. I'm going to expose that area immediately. I'm not going to be asking all these questions, by the way. Really nasty bruise? Miss, I don't think it's a bruise. I think it's a laceration.
That car came out of nowhere.
Car came out of nowhere. I have no
Remember
idea.
much afterwards.
She's getting with all the blood, a red tag
No issues
right
that
off
I
the
know
back. No issues that you know, but she's ANO times 4. That's really big.
Nothing prescribed, just some headache pills.
Okay, I would not be asking her all these questions. Yeah, calm down a little bit,
That
miss.
feels better.
Okay, I'm going to do a quick assessment. I'm really just going to focus on her leg. Strong bleeding. Okay, she needs to get bandaging really quick. I would tell my partner, hey, go ahead and bandage this patient up. Make sure it's not arterial, and I'm moving on to the next patient. I have this patient laying down on the floor.
Pain in my upper left arm.
Pain in her upper left arm. I don't see any obvious
I
bleeding
have a
right
really
now.
nasty bruise.
I'd move on to the next patient. What happened?
That car came out of nowhere.
Okay, everyone's saying the exact same thing. I would leave you. If this is a real call,
I haven't
you're
had
fine.
any chronic illnesses. No.
There's going to be
I
so
haven't
many
taken any
C-collar
medicine.
backboards that are going to be put in place. Okay, come on, miss. Come on.
I'm starting to feel better.
Beautiful. Okay, triage this patient. You're green. Actually, can I look real quick? What's going on in her arm? Hematoma? Okay, you're getting a green tag, miss. Miss, you're green. Miss, you're red right now. Triage. E. Okay. Let's see. We're going around. We're looking at all the vehicles. We're seeing anyone who's involved. This is not a good call to be responding to. No one's in a vehicle. That's good. There's no one that's obviously trapped. What's going on with you, sir?
Arm hurts.
Your upper arm hurts? Looks like you're bleeding out already. Can you tell me what happened?
I was in such a hurry.
Okay, you didn't.
I didn't see
Everyone's
the car
going to tell me
coming
the
at
same
all.
thing. That's fine. Oh my gosh.
I have a really dark bruise.
That's okay. Good. How can I be of
I have
assistance?
a really dark bruise.
I would not be asking this.
No chronic problems.
Would you consider a whole blood protocol in the field?
No, didn't take any meds.
Or would I give diesel therapy? I'll go over that question in a moment.
I'm starting to feel better.
You're starting to feel better? I don't believe you. I don't believe me asking that is helping you. Let's see what's going on here. Quick scan. He's continuously bleeding out. He's got a lac. We need to control this bleeding immediately, or this patient's going to bleed out, right? You're going to get a red tag. I would get my partner to bandage that patient, and then I'd tell my partner, hey, after that, come over here and bandage this patient. Go. Oh, that might be a DOA. Let's find out.
It hurts everywhere.
Hurts everywhere. Okay, what's going on?
I have a really nasty bruise.
Everyone has a nasty bruise. That's okay.
That car, it came out of nowhere.
And it's
I
really
don't remember
tricky to
much
not...
afterwards.
Oh my gosh, I think I
No
clicked the
issues that I
wrong
know
button.
of.
Come on.
Nothing prescribed.
It's really tricky
Just
to
some
find
headache
every
pills.
patient here, right? You can see if any bystanders are hovering around patients,
Feels better.
but we're going to do our best initial intervention. Can I see anything? What's going on here? You're underweight? I do not care. I do not care about that at all right now. Hematoma to his chest. You're getting... Not sure what's going on there. This patient... Can I not even scan her? Black tag. All right, well, that was easy. Go to next
My
patient.
upper legs hurting.
Upper legs hurting. How can I be of assistance?
I have a really nasty bruise.
Come on.
That car, it came out of nowhere.
Okay.
I don't remember much afterwards.
It may be
I
kind of
haven't
messed up
had any chronic
going right past a
illnesses.
black tag
I'm
patient.
here. Come quick. No,
Oh.
I haven't taken any medicine.
But unfortunately, that's part of
I'm starting
triaging,
to
right?
feel better.
Black tag means that they're deceased.
Can you help me?
Okay. What's going on here? Scan. Okay, you have some obvious bruising here. Strong bleeding.
Help.
Okay, that's horrible. We're going to give you... Can I not triage him? I did not triage this person as green. I don't know why I did that. What's going on here? No, I need to find out.
Got pain in my right thigh.
Again, I would tell my partner, hey, bandage this person
I have a
next.
really
And we'd be throwing on
bruise.
quick bandaging. If the bleeding isn't controlled immediately, you know, you could skip
I was
straight
in
to
such a
tourniquets for
hurry.
something this big.
I didn't see the car
Come
coming
on.
at all. No issues that I know of.
Okay. Okay, come on.
Nothing prescribed. Just some headache pills. This way. That feels better.
Okay. Triaging. You've got a life bleed. What's going on here?
Over here.
Strong bleeding. Hematoma. Congratulations. You're red tagged. Oh my gosh, this guy too? This is what is going on with this call? Right lower leg hurts. You're bleeding out. You're bleeding. You're all bleeding out.
I have a really nasty bruise.
Okay. But if we're being serious here, okay, tell me what happened,
That
blah, blah.
car came out of nowhere.
Car came out of nowhere.
I don't
Everyone's
remember
saying
much
the same
afterwards.
thing.
I haven't had any chronic illnesses.
Okay, that's good, miss. Do you
No,
regularly receive
I haven't
treatment?
taken any medicine.
What's going on? You're starting to feel better? I don't believe you.
Better.
Tag. Hematoma. Yup, you're miss. You are actually probably looking the worst out of everyone I've seen so far. Strong bleeding. You have earned yourself a red tag. Okay, there's a lot of people too. Are you just dead? No reaction? Hematoma? Yeah, massive hematoma. I have a nasty bruise. Okay, buddy, you're getting a black tag. You're deceased.
Got pain in my right thigh.
Sometimes you just you got too many critical life bleeds here. You're
have a
black
really
tagged. If anything, we can revise our tagging
bruise.
in a moment. What's going on
I
here?
was in such a
hurry. I didn't see a car
I
coming at
didn't
all.
see the car coming at all. No chronic
No
problems.
chronic problems.
Don't leave me here.
Oh,
Don't take
I didn't take any
medications.
meds.
Calm down. Great, you're starting to feel better.
Starting
Awesome.
to feel
That doesn't make
better.
any sense to me, but okay. Hematoma. It looks like you're don't have a hematoma. It looks like you're bleeding out. Head checked. Okay, good. Assess.
Please.
Okay,
hurry.
you get a delayed. You're fine. Are you a patient?
I don't know how to answer that. Sorry.
Okay, move. Get out of here. I've already tagged you. All right, so we've got all of our patients. If there's another patient, I don't know where they're at. So what am I going to say now? I've got all these patients tagged. We have 4 red, 2 yellow, 1 black. All right, I'm going to do something like Medic 72 to all incoming units. I currently have
I need help.
4 level 2. Actually, I'll say Medic 72 to all incoming units. I currently have 6 level 2 patients. I have 2 level 3 patients and 1 level 1 patient, or level 4 patient. Currently going to need approximately 6 medical units or ambulances at this time. Nobody is currently trapped in any vehicle. No rescue is required. Also, go ahead and send me 2 extra or additional engines at this time. And then usually a battalion chief will show up on scene, and you'll kind of transfer command to there. If you show up on a call like this, right, you are basically going to leave with the least injured patient out of everyone here. You are going to transfer over the most critical patients. So for my red tag patients that are bleeding seriously, I'd pick the most critical one at first. And as ambulances start to pull in, I would transfer my most critical patient to that ambulance. And then as engine companies come, they can help stabilize patients and prepare them for transport. And we're basically going to leave with the least critical patient. However, for this game, they require you to take the most critical patient, which is okay. All right. Major incidents stirrup to control. Do you follow methane or some other format? I use levels personally a lot whenever I'm on the field. I'm just going to go to this person. It's fine. Unless they already bled out and just passed away. I don't use methane. I use the START triage system, and that works really well for me. Also, great Powerade, you said, would you consider a whole blood protocol willing in the field while in a city service with hospitals in a 10-minute distance, or would you just give diesel therapy? I like to set up appropriately whenever I have a patient. So yes, I would use whole blood administration. I'd also consider TXA administration. I don't have access to whole blood right now, so I'm unsure if TXA has any contraindications with whole blood administration. But at the very least, I'm considering TXA. And for patients like these, I think whole blood would do just fine. So I would administer TXA to assist with the clotting process to increase the overall clotting mechanisms in the body. And then I'd also put on a appropriate dressing onto the patient. If I have like a hemostatic dressing, that would be really good. I'm not a big fan of using tourniquets, but if you have this many patients and you're throwing on tourniquets quick, I think you're fine with that. Oh, methane is a major incident multiple report, not a triage format. We use it for TST and MITT. I'm going to have to look at methane later. I'm going to pull up on the side here. Google methane report EMS. It's super cool. I've never heard of this. Major incident declared, exact location, type of incident, hazards, access and egress, number and severity of casualties, and emergency services present and required. That's cool. I've never heard of that. But the biggest thing is you want to give people an idea of what's going on. You want to cancel rescue if it's unnecessary. Isn't it with TXA and whole blood, you just have to have dual bore IVs and administer them separately? I've never administered, oh, good to see you, Cole Breeze. I've never administered whole blood in the field before. Although that makes complete sense to me. Usually with whole blood, you're just going to have a separate arm in general. And so I'd have whole blood administering on one side, and I would have TXA going on the other side. I agree. We're going for bilateral 18 gauges. This is a good example of where you can consider a 16 gauge IV, although I think 18 gauges are just fine for something like this. I think that 16 gauges are touted too much in paramedic school. And should be reserved for the most severe call. Although I think that this would be a great example of a good 16 gauger. Okay, so we're going to go ahead and throw this patient in, and I'm going to gather some more information. Sorry, this is off topic, but I have a question. I passed my EMT last month, got licensed about 3 weeks ago, but I'm nervous. My program was 3 months, but we barely did any hands-on skill. Then this stream will work great for you. We never touched a C-collar, only kind of practical holding C-spine, and used this backboard and a stair chair once. I only had one ride along, one hospital observation. I only feel confident with CPR tourniquets. That's completely normal, Bosnian. That is completely normal to feel underprepared. You just finished an EMT program. I mean, how long was your EMT program? What was it, like 3 months at the most? Oh, it was 3 months. Yeah, you learned so many different things. You touch up on trauma for like a week or two. Don't worry about that. The important thing is to understand where you're at and to seek out further education, right? My recommendation is go to medic school, but it's up to you on what you want to do. All right, so let's see what's going on with this patient. Is this patient even conscious? Hey, did I put a dead body in my box? Uh-oh. 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 Okay, I would not have normally done this if I knew that this patient was dead. Uh-oh. We need to check a pulse immediately. Uh-oh. They're checking cardiac. Let's get a blood pressure on him. We need to put a dressing there. No. Blood pressure is normal? Wow, that's incredible. Okay, even though I have my blood pressure cuff there, can I go ahead and put that? Oh my gosh. Blood pressure cuff. We're going on this arm instead. Can I undo that blood pressure cuff? How do I take off a blood pressure cuff? Please let me take this off. Please let me take this off. How do I take this off? Blood pressure cuff. Remove. Blood pressure cuff. Remove. How do I remove a blood pressure cuff? How was I supposed to know that this was here if the arm wasn't... Can I take you off? Fellas, this is a disaster. I was in the exact same way when I got my EMT. My instructors essentially said you'll learn everything at your service. That's exactly how it is. Classroom is always different from the field. Don't worry about it, buddy. You're good. Cobean, we're in a lot of trouble here. We should be putting a dressing on this patient, but it's not letting me because I have... It's fine. I'll start an IV on this patient at least. Let's get some normal saline. Oh, it's a mini game? Beautiful. I'm so clutch. All right, we need normal saline on this patient. This SpO2 is low also. Let's get SpO2 going before that, actually. Where's the oxygen? Okay. I'm cool with this. Let's put on a non-rebreather. I'm throwing it right at 15 liters per minute. Setting at 77%. Okay. Is it not going to let me take off this dressing? Please? I don't think I need a dressing here. All right, whatever. Okay. You know what? Whatever. At a certain point, we just got to kind of accept what the game will let us do and what it won't let us do. As long as we're covering up this area, I think that's fine. Okay. Please let me unequip this thing. Do you plan on doing nursing and medic firefighter at the same time? Yes, I do. I'm planning on working 911 and at the ER at the same time. No, Bosnian, don't worry. I wasn't a good EMT-B till I was halfway through medic school. So, and that was for an EMT-B, so don't worry about that. It's completely normal. Okay, guys. This is a complete disaster. Okay, we have a patient who is potentially bleeding out of their right arm. It's not letting me take off the blood pressure cuff because this game's evil. But you know what? It is what it is at this point, right? What are some things that we would consider in real life? We're going to do normal saline administration. I would be talking to my patient too. We also need to check lung sounds. Okay, I hear movement, even though it sounds goofy. Possible some fluid in the lung, so what are we worried about? Maybe they're developing a what is it called? A hemothorax? Not good. We'd consider something like a needle decompression, depending on the patient's presentation. I can administer saline, right? I can't even administer saline. Okay.
Don't delay transport. Let's go.
I agree. Can I put some bandaging on this patient, please? 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 All right. You know what? We're out of here. Okay. So this isn't good. The patient's cooked. Alice, I agree. The patient is not doing hot. So during triaging, we are the last ones to leave the scene. What are some things that we needed to do differently? We need to not be leaving the scene. We need to be. We need to stay with the most stable patient. We need to apply a dressing. We need to administer saline to that patient. We need to administer TXA to that patient to help with possible internal bleeding that we may not be visualizing. I'm not able to talk to our patient, but we need to be asking person, place, time, and event again and again and again. We can keep him warm, exactly undefeated. We can worry about, hey, you know what? He's really uncovered right now. He has blood loss. Let's apply a blanket to this patient. If we're able to talk to him, we need to ask some questions. Were you hit by the vehicle, or were you in the vehicle? Let's say he was in the vehicle and he got into an accident. How fast were you going? Were airbags deployed? Were you wearing a seatbelt? Are you using any blood thinners at this time? And did you lose consciousness? All of those questions are really important. What did you hit? What vehicle were you driving in? Let's try to gather as much info as we can. TXA helps break down internal blood clots, right? TXA more so helps with the blood clotting process in general. Let me see. I can actually find the patho for you real quick. TXA, Google. Mechanism of TXA. It prevents excessive blood loss from major trauma, postpartum surgery. Let's see. What is it? How does the mechanism of injury? Come on. It stabilizes clots by inhibiting the breakdown of fibrin, thus reducing blood loss and improving homeostasis. So this medication would be so great for this patient, right? I'm not able to push TXA in this game. Where does TXA work in the clotting cascade? It stops the breakdown of fibrin, which is one of the multiple actions that occur during the clotting process. But it'd be great. It'd be awesome if there was an EMS simulation on 5 right now and just role playing with everyone. There's a simulator for firefighters. But yeah, there's a really realistic paramedic simulator being developed. paramedic EMS sim. I'll have to check it out. I would have other responders, firefighters, EMTs stay with the other lower priority. Exactly right. They need to... so that's a great question, but we need a paramedic kind of like on scene. And I would work so more so on stabilizing the patient, right? But anyway, okay, enough about this patient. Let's get him going. This ain't looking too hot. We should not be leaving the scene without any of the providers, but we need to get going. For this call, at least. 5M is just GTA, but role-playing. Sounds like a lot of fun. Okay, we're going lights and sirens. We're going code 3 with this patient. I'm trying to read the chat at the same time. I feel like they should enter paramedic scope, practice IMO. I don't know what you mean by that. But yeah, this patient would be a great candidate for TXA. Also, if he was alert and oriented times 4, depending on how severe his pain is. Oh, okay, I don't know why this patient ran in front of me. Right off the back, I'd lose my license for that, right? Let me make sure I have this turned off. Okay, disable pedestrian collisions. Okay, we don't want to hit people. Okay, come on. Come on. This is just a video game, guys, so the driving does not matter. Okay, pulling in. All right. Let's give a little breakdown to the hospital how we do this. This is a 33-year-old female patient. I also forgot to give them a category, but we'll get better at this game as we progress. Medic 72 to spawn to our line. Medic 72, go ahead. Medic 72, I'm coming in code 3 with a 33-year-old female patient. I'm just going to assume, guys, that I was able to ask them more questions. With a GCS of 15, patient advises that they were driving a vehicle whenever they hit... I'm making up stuff, right? They hit another vehicle. Patient has a laceration on their right AC. Patient's last set of vitals, BP is 122/84. I'm just making this stuff up. Satting initially on room air at 74%, but currently at 95% on a downward breather at 15 liters per minute. Temperatures at 98.8, and heart rate is at, I don't know what it is, like just say 96 beats per minute. ETA facility in 1 minute, which they do not appreciate. And then we'll just go from there. Oh, look, I have the vitals. BP is 135/90. Setting at 100%. Temp is at 99.2. And the heart rate, I didn't get it, but whatever.
Let me see. We take over from here.
This would also be a good idea if your battalion chief can do it. It gave me an A. I actually thought I did pretty bad. Where you can alert the hospital prior to transport. Or if you have like an engine company on scene, tell them, hey, go ahead and let the major trauma hospital know that we have a mass casualty with approximately, let's see how many patients. 1, 2, 3, 4, 5, 6, 7, 8, 9, with 9 patients. In the event you have a critical patient and the nearest hospital is 10 minutes away and a hospital level 2 trauma is 25 minutes away, would you be willing to go the extra 10? Yeah, I'm going to go to the appropriate facility. Because let's say if I have a patient who has a critical life bleed and I go to the hospital that's 10 minutes away, yeah, they can work on stabilizing him somewhat, but maybe, especially because we had that bleeding on the right side of his torso, what if he needs like a chest tube or something? What if he needs surgery? You know, the worst thing that could happen is they stabilize him a little bit, yeah, which is kind of ideal in some sense, but then they need to contact another private transport company to take them over to the other hospital. But this is a great reason to call in a heli, like how Alice is mentioning it. Depending on how far away the hospital is and how many units you have, if you can just get the appropriate number of hospital or ambulances to your scene, you may not actually need a heli. That would more so be so if you have a burn patient, and let's say if they have a third-degree burn on, like, let's say like 30-40% of their body, and the nearest burn facility is approximately 2 hours away, then maybe we need to go with a heli at that time. And even then, they may have a helipad at the hospital, and they can stabilize it and transport them that way. Happened at my service, a crew took a skull fracture patient to a clinic because the trauma center was too far away. See, that's not, I can never say if that's appropriate or not because I wasn't there on the scene, but they should go to the trauma center. It's not appropriate to go to the nearest hospital. And the NREMT really pushes that. But you know what? We all make mistakes sometimes. We're practicing medicine. Okay, end of shift. Beautiful. That one patient got tagged with an A, or with a minor. I disagree. I think that he should have been a critical tag. Our MCI protocol says the first crew on scene to give methane report and assumed initial command or incident command until operation manager takes over. So the only triage but not transport. See, that's perfect, what you're describing there. And honestly, whenever I showed up on scene, one thing that I should have done is I should have said, Medic 72, I'm on scene, I'll be establishing command. So that's something that I forgot to do. If the nearest facility can stabilize adequately, then I'm probably going to... No. If you have a patient whose blood pressure is fine, oxygen is fine with interventions, but they're critical and they're trauma, Alice, you need to go to the appropriate facility. You need to go to the trauma center. I understand your mindset on that. The only time I would do something like that is if it was like a choking patient or if it's a cardiac arrest call. But we've unlocked some new protocols now. But a good point, Alice. No issue with that. And good to see you, Jet Umbrella. Congratulations, Paramedic. We've unlocked some new things. Utility worker call-out, a tourniquet, morphine, saline solution, and a ventilator? Why do I have access to a ventilator? The only time you use a ventilator is if you're doing private EMS transport for like interfacility transports. And if you're going from like, let's say an LDT or a long distance transport. Yeah, it's crazy grape. They didn't give me jack early on. I also just got access to saline. You'll only use a ventilator, let's say if you have a patient who, don't worry about it, Alice, who you're going to another facility. Let's say they're about like 2 hours away. They're knocked down with, let's say like a sedative, like propofol, and a paralytic, like raconium or something. And you have like some certain drips set up, then you can have them on a ventilator at whatever setting you need to have. And you're transferred from one facility to another. And it's always good to write down the ventilator settings at the hospital. That way, whenever you transfer over, it's a smooth transition. Imagine if the paramedic scope had a level system where you had to gradually unlock stuff as you go. That'd actually be pretty cool. The only issue is that the disservice that it could do to a patient in the field. Yesterday, I got commended at my clinicals for taking to my private throughout the 25-minute transport to the hospital, keeping them distracted. Yes, Kobini. I actually read through all of Chainsaw Man, by the way. I'm kind of a nerd, but fantastic. Sometimes, especially rideouts or EMS personnel in person, don't realize how important it is just to talk to your patient to get their mind off the actual scenario. You know, don't let them wallow in their own thoughts. Don't let them freak out. Talk to your patients. That is something to be commended over. And I'm glad they recognize that. Sounds like private EMS, yes. Long distance transports is private EMS. That's where you make more money in 911, or that's where you make more money as a paramedic, but you also lose a part of yourself over time. I've done both. Okay, I told somebody that we do the venous bleeding training. Oh, arterial bleeding. I want to do that too. Let's do venous bleeding. I told them I'd do it. Training venous bleeding, a special shift designed to teach you how to handle specific patient scenarios. We're going to go through one scenario where we consider venous bleeding. Perfect. Me personally, I'm asking the patient about hobbies. That's perfectly fine. That's great. Whenever I was riding out one time, I had a patient that I remember, a lot of people were kind of being mean to the patient, but I was like trying to talk to them, and I was asking them about their personal life and everything. They were a long-term abusive alcoholic patient. And this was years ago, though. And I remember I got down to the level where the patient was basically crying to me because they were having such a horrible mental breakdown. But I was able to really connect with my patient. Talking to them and treating them as a human is so key for calls like that. I think that you should be commended again. We have that level system here, gradually unlocking stuff in the scope as you climb the ladder. I think Austin does that. Or maybe not Austin, but there's some northern state in Texas that they have different levels of paramedics. I think it's really cool. But let's do a venous bleeding scenario. Thoughts on ALS crews taking CITs? I don't know what CITs are. What is a CIT? I wish I was better at talking to patients. Don't worry about it. You'll get better at it over time. Use sample and OPQRST. It's a great idea. I wish I was better at talking to patients. I'm getting better at least. I try to understand why the patient is there and asking relevant questions. Any tips? Use sample OPQRST and then go from there. And talk to them. You can even talk to them about your hobby.
As usual, we should enter the ambulance.
Miss Johnson, I'm starting to really enjoy working with you. You're really positive. Let's go see what this scenario is.
Calling ambulance 152. There have been reports
Further
of a bicycle
south,
accident in
Australia.
downtown
Yeah,
Melbourne
Australia
Park.
has
Person is-
one of the best EMS providers out there. Crisis intervention team. What is it? What else is it called? A crisis interventions team, CISM. I had the chance to be on a team like that. I chose not to, but it is good to know. All right, but let's focus on the
Bleeding
scenario
heavily.
first, then I'll go back into questions. All right, we're responding to a
Please head over
patient.
immediately.
They had a bicycle accident downtown in Pelican Park. One patient is bleeding heavily. Respond
We're
immediately.
on our way there now.
There should be a way in this game. Oh, we should always do lights and sirens. In a real life scenario, by the way, when you're responding to a call, if you're ever going lights and sirens, you never should cross through people like that. You always stay on the left side of the road. Why do you always stay on the left side of the road? Unless, like, I guess you live in Europe or something. It's because you don't want people to pull over and get pushed off into the sidewalk, right? So people can divert a little bit out of the way. Usually they go to the right or they may move a tiny bit to the left. If I were to stay on the right side of the road, though, you see how these cars are starting to move over towards the sidewalk. Here we can't help it because it's a single lane, but if it's a multi-lane area, then we definitely want to stay on the left side of the road. Okay, come on. And common courtesy for everybody on scene, and just kind of a general practice. Again, as you're pulling up to this call, right before you get to the call, you're going to want to turn off your sirens. So we'll get really close. Plus, it's really annoying for everybody on scene. You call it Pacer there? Cool.
This should be the correct location.
Where the heck is my
Let's
patient?
try
Okay, this is
locate where the
goofy.
accident happened.
Alright, right here I would turn off my sirens. Right? And then normally I wouldn't do this, but since this is a video game, I don't want to move my stretcher that far. We're pulling right up to the patient here. You don't want to get your ambulance stuck is the only thing. Okay, let's see what's going on here.
Sometimes there are witnesses
Okay, let's talk to the
present
most
around
critical
the scene.
patient
Everything's
first.
turning
They might be
black.
able to help us.
Everything turning
Oh
black?
God, you're here.
That's
We can
not
approach
good.
them just like
What
patients.
happened?
I'm not sure. I was on my bike, my usual route, and suddenly I completely lost control.
Suddenly completely lost control? Okay, so I'm assessing my patient, right? In real life, if you're the EMT on this call, while I'm doing this, get me a set of vitals. That is so good to get while I'm working on asking my patient questions and doing a rapid assessment, right? And sample OPQRST, again, will carry you a lot, at least as you're going initially on this patient. Where is this bleed at? Strong bleeding on the leg? Okay. Can I open handbook? What does this do? Can I treat patients out of the ambulance? I don't think I can. That's a shame. Okay, I've assessed my patient. Right off the back, they have blood bleeding from the leg. I'm going to say it's a hemorrhagic emergency. Venous bleeding, I can't tell. But unless it's spurting, I guess it's fine to say that. Right? That's how we make the distinction. Question the witness. Okay. I would focus more so on the bleeding, but that's fine.
Yeah, we were riding through the park together, like always. Suddenly, there was this huge bump in the road. I'm glad I missed that one.
The witness report
Okay.
seems to indicate external factors as the cause of the crash. I will mark that down on the patient chart.
Okay. Some other things that we're looking at here, right? Patient's laying down on the floor with the bike that's on the floor. It is odd. Maybe they just hit a bump in the side or in the park. I couldn't really tell from what they were saying, but we need to see where the patient landed, right?
Once
If we
we're
look,
done here, go and get the strap.
the patient landed on gravel. That's what I'd call it, or like a dirt road. So we'll just say patient landed on a dirt road. We need to feel for their neck and back and see if they have any neck and back pain. If they do, we apply a C-collar and a backboard. Okay? I don't think this game will let me do that, but it's what I would consider doing. They have some decent bleeding from their right lower extremity. So we're thinking, okay, we need to bandage up the area if it's still bleeding currently. We can use a hemostatic dressing. If it's spurting out, it's arterial. If it's just rolling out, then we consider it venous.
So we can tend to
Okay.
those wounds
We need to ask the
properly.
patient, did they lose consciousness whenever they fell? Are they on any blood thinners? We need to check pulse motor sensation prior to moving the patient and then after moving the patient. That's why I would bandage on scene, but I
Side
can't do that
ambulance.
at this time. And a backboard C-collar would be really good here. If they have any neck or back pain. If not, I'm not going to use a backboard C-collar. Okay, we would not pick up the patient this way. We can help it. We would use a backboard specifically to even pick up the patient and just leave him on it. But that's fine for right now. Okay, let's get some baseline vitals. We need to bandage this patient also. We do XABC here, so I
should
don't
attach
think
the
that
usual
bandaging the
diagnostic
patient is
tools
fine.
first.
Or initially first.
Afterwards, we should really take care of any bleeding wounds.
Okay,
using
it's
the
saying to use
bandage tool.
diagnostic tools first. I'm actually really cool with that. I kind of like that. Okay. And again, we don't need to expose a patient this much. There's no need to do that if we're just applying a BP cuff on a patient. Right? We want our patient to feel comfortable. We're putting a pulse ox on a patient. Okay. And we put the pulse ox on a different side from the blood pressure cuff. Okay. And we have we'll go into that in a moment.
Give me some space.
Oh, okay, miss. Chill out, chill out. I'm just trying to help you. Okay, we got to do a little mini game. I don't care about this mini game. Oh, okay.
Breathing room.
How am I missing? Okay, it has to light up. That's fine. Beautiful. Beautiful bandaging skills.
Nice job. Once we've taken care of all the wounds, we should drive the patient to a hospital.
I disagree. Okay. So what do we see here? We see a blood pressure of a 111/74. That's a normal blood pressure. We're happy with that. Heart rate's at 105. Patient may be in some pain, right? I don't know how to assess pain in this game, but if they are in a decent amount of pain, why not administer some pain medication? Actually, no, the blood pressure is too low. I'm not doing that. 108 on 72. I'm not comfortable with that. Heart rate at 105 probably explains it. Oxygen or satting at 100% SpO2 is good. Can't test their blood sugar right now. The game won't let me, but I don't think I would need to. And temp at 98.9, it's good to know. If I triage this patient, they would be getting a green tag. Okay, am I able to see anything else here? No, they're just tachycardic. I'm cool with that. Is there any other treatment options that I have here? I think starting an IV would be great for this patient, but it's not letting me. Okay, let's see what some of your questions are. I just learned what a traumatic arrest was yesterday, and I was looking through pager history on app, and it had something about a traumatic arrest. I had no idea what it was. Just a cardiac arrest that was caused due to trauma. Would we do a head-to-toe assessment for something like this? Yeah, you could. As you're transporting the hospital, we go from a rapid assessment to a full head-to-toe assessment. So as we're transporting, that's a good idea. We also bandage the patient. So before we bandage and after we bandage, we're checking pulse motor sensation. Would I ever want to learn something like suturing or simple suturing? I don't have an issue with that if that's in my protocols. The thing is, simple suturing is a nice idea on paper, but are we using up more time on scene than we need to? I kind of want the physician to see how deep the injury is, and I want to, by suturing, I kind of take away from that. Also, what is if the wound needs debridement, right? Then are we doing a disservice by not debrining it, or administering some type of saline administration or some type of administration to maybe sterilize the area a bit? It sounds good, but why not just do bandaging or applying direct pressure as we transport? So I'm kind of against it, Cool Breeze. I know people are always pro more protocols, but I can see why we're not able to do that. Could we administer Tylenol for mild pain management or ibuprofen? Yeah, if that's in your protocols, I think that's perfectly fine. As long as the patient's ANO times 4. You're saying psychological intervention, paracetamol. I'm not too familiar with that medication. Ibuprofen for pain management. Yeah, I'm cool with that. Tylenol, or as we call it, paracetamol. That's what you're calling it as. Isn't contraindicated. Yeah, I'm really cool with that. I think that would be fine for the patient, especially because I'm worried about their blood pressure right now. No, I'm not really worried about it, but if I administer pain management like morphine or fentanyl or something, although some argue that fentanyl doesn't drop their blood pressure, I may be doing more harm than good, right? Because I may cause them to go hypotensive, even though that reading's still considered normal. I don't want to go from normal, or the low ends of normal, to hypotension. Their heart rate's elevated, so a 4 lead would be a good idea too. And you see here, this is an issue that I have with this game also. We're rolling in our patient with their shirt off because we did a blood pressure check. Think about all the onlookers. Think about everyone that's seeing this patient. So if we took off their patient's shirt for whatever reason, let's cover the patient back up with a shirt, or at least take a stretcher sheet and cover over the patient. You know, why are we exposing the patient needlessly? We don't want to shame them.
We take over from here.
Yeah, we don't use brand
Good work
names
today.
in
Here
Australia,
are your
and
results.
acetaminophen is called
This concludes our training
paracetamol.
shift
That's cool.
together. I'm glad you're learning so quickly. Your future
Miss
work
Johnson, I'm glad that you're
is
teaching me.
to provide better medical services across
You're
the entire
you're a
country.
damn fine trainer. Damn fine work, Miss Johnson.
Keep it up, and I'm sure we will work together again.
I hope
really
so.
soon.
She's super positive. This is how you should be in EMS. A B? I got a B? What else did I need? Why? Does it tell me why? Pale skin, mist, seam red. Oh, did I not visualize my patient? Mute? She's mute? She talked to me. You liar. Oh, no. Crashed? I'm supposed to visualize that better? You know what? Maybe it's something I can improve on. That's what I get. Remember ABCs. Oh, ABC and F, fentanyl. I'm actually more of a morphine and ondansetron, or like Zofran person, whereas a paramedic, I like to administer morphine a lot. It's kind of my go-to gal. This game needs some more development? Yeah, but I like the scenarios because it gets us talking. Look, the blood sugar's at 77. Depending on your protocol, some older ones are still at 80 on 120, although 70 at 120 is fine, and some text even say 70 to 110. Blood sugar, I don't like it being at 77. I'm not going to treat it, but I'm going to make note of it. You know, maybe we can ask about their past medical history. If their blood sugar is at 77, hey, maybe, you know, they, what's it called? They may be diabetic, and they may have had an insulin administration without breakfast this morning, and maybe it's going to tank even more later. So let's go through sample, right? We have green whistles, methoxyflurane before going for an opioid. It's cool. I'm not familiar with it, but that sounds very progressive. Can I unlock some new stuff? House fire call out? What? Burn bandage? What's a burn bandage? What, does it have like some solution? We're not supposed to do that. We use moist sterile dressings for, wait, actually, no. We use dry sterile dressings for burns. Let me double check what I'm pretty sure it's dry sterile dressings. Yeah, you almost caught me on that. Okay, I almost messed up on that. It's dry sterile dressings for burns, moist sterile dressings for any abdominal organs that are protruding. We cover them with the moist sterile dressings. We don't use a moist sterile dressing for burns because it can steam, right? This is cool though. House fire call out. Your heart rate might be above normal, but hey, at least your SpO2 is at a perfect 100%. 95 to 100 is all perfect, in my opinion. But anyway, this is cool. How do I do the... Whoa, where'd it go? I already did my training. How do I do the fire calls? I already did the training. I don't want to do the training anymore. Let's do a poll. Start a poll. Which scenario do we do next? We got some options here. Regular shift. We got the panic attack. And we have training arterial bleeding, which I think is kind of cool. I know where my vote's at. I'll let you guys have a moment, and then I'll talk to you about it too. Okay, so we have some cool things. We have broken ribs. So what are we thinking broken ribs are called? Depending on how it's broken and how the chest rises and falls, we may have something like a flail chest on our hand, right? We have burn bandages, which is a dry sterile dressing. Sometimes if you have a burn patient, you can apply like let's say water, or I would use sterile water to the burn to try to cool it, but then I would try to almost like pat it dry a little bit and then utilize a dry sterile dressing. Because again, we don't want the area to steam, but we like to stop the burn if we can. Also, if the burn is electrical, then what do we need? We need a 12 lead EKG. We need to see the beginning of the burn or of the electrical injury, if they got shocked or if they got hit with the lightning bolt or with lightning. It may initially seem really small, but if we look at the exterior portion of it or the part where it escaped from, that's usually a huge blowout, a huge trauma. Super cool. Okay. I think regular shift has a chance to have that scenario. I think so. I was hoping it would be like one of these that I could click. Our burn bandages are straight up shower curtains. That's pretty cool. That's very interesting. I don't even know what I would do in a scenario where I had a patient with a flow chest. So they used to say to wrap the patient up, and you would try to keep it so that the flail chest portion and the regular rib cage should move up and down as you inhale and exhale together. Now they've moved all the way to where you don't really do anything. All you do is assess the patient and you transport to the nearest hospital, because whenever you manipulate the bones, you can potentially cause them to stab or poke some arterial or venous blood vessels, so it can cause other issues. With flail chest, don't you put a pillow between the patient's side of their arm? You can do that for positional comfort. Honestly, I would just stabilize them and get going. And couldn't a severe burn, non-electric, cause a loss or misbalance of electrolytes? Yes. Yes, it can. It can cause a potassium issue. And so we would always assess for cardiac maladies or cardiac imbalances or abnormalities. Yes, you're absolutely right, Cold Breeze. We're worried about their potassium level. Although we can't properly assess that in the field. Okay, we have a tie. We have a tie. I did not expect that. We have a tie. Next person to type what to do gets it. Whoever types first. I'm so excited to start working. I don't have a wheel, otherwise that'd be really fun. Got to do my drivers first. I have my learners, just don't have my full drivers. All right, regular shift. We're doing a regular shift. Then we'll go to more training later. We're hopping right in. Always check vitals on patients. What a great tip. I agree. I like to check vitals before I even move my patient. And I'm with Ms. Johnson again. Fantastic. She has become quite the staple of this game. Let's go, Ms. Johnson.
Dispatch to ambulance 152. We need immediate response. Over.
Immediate response. See what's going on.
We received a report of a severe accident in the vicinity.
Severe accident.
The report indicates at least one injured worker.
One
maybe
injured
more.
worker, maybe more.
Some sort of blast.
A
happened
blast!
On a small construction
That's
site,
really cool,
reason
actually.
unknown.
I have to look up blast injuries super quick so I can talk about it with you guys. Blast injuries, EMS. Okay. So there is multiple things you have to worry about for a blast injury. We have the primary injury, which is the pressure wave. It can affect gas-filled organs, leading to tympanic membrane ruptures, blast injury, like pulmonary. I can actually just pull this up here, right? Why should I pretend like I know this by heart when I can just pull this up? We have primary blast injuries that can affect the gas-filled organs, like the tympanic membrane, so I guess like the ear, the pulmonary barotrauma, abdominal hemorrhaging, perforation, and traumatic brain injury. Interesting. Secondary projectiles, the shrapnel, caused by flying debris, broken glass. You can have lacerations, trauma. We can have the tertiary injury, which is caused by, let's see here, solid objects, like maybe they flew into solid objects or that were hit by solid objects, can cause amputation, fractures, and blunt force. And quaternary collateral, any other explosion-related injury, including thermal, flash blindness, crush injuries, and inhalations that's toxic. Let's see. So it's essentially possible internal bleeding everywhere. Yeah, we can have so many issues going on with the blast injury, which is super cool that they're even talking about it.
Sending you the location now. Hurry up. Over.
Were you guys able to see that pop-up that I put on there on the screen? Not that's okay, but let's go code 3. All right, everybody on my side. This is somewhere where it actually would cross the lines here, but I'd be going really slow. Get out of my way, get out of my way. Go, 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 go. Get out of my way. I'm parking. I honestly wouldn't like to park in the flow of traffic. Get out of my way. How am I going to park here in real life? I have a patient right up there. In real life, I'm parking right here. I think I'll be fine like this. This isn't ideal, but I'll just go right here for right now. Let's find out what's going on. That is very dangerous. We have to be really careful because it's sparking at this time. But let's find out what's going on.
In my left upper leg.
Pain in their left upper leg. What's going on?
My skin is so warm.
Oh, look, we have blistering on their arm.
There was a sudden blast, and I felt intense heat. I tried to cover my face.
Someone
but my
struck a
arms
gas
got the
line.
worst of
Well,
it.
let's see.
No, I've always been quite healthy.
Good, good. And they're talking to me right now. They're ANO times 4. They have a
No,
GCS of
nothing.
15.
I don't like medicine.
You don't like medicine? You're about to get a lot of medicine. So, it's not good.
That feels better.
Okay. Let's see what's going on here. Okay, red blisters, inflamed skin. Also, I want to see what's going on in their leg here, right? Okay. Can I look at the electrical panel? Okay, we have electrical sparks coming from here. We'll need an engine company on scene, and they may need to call AEP or something to discharge this or to cut off the power to this particular area. Also, we have some bloody pliers. Maybe they're working on it and they're flung out and hit them in the leg, and that's what's going on. But let's go ahead and grab our stretcher. Choose my interim diagnosis. I'll just go for the environmental hazards. I guess it's fine for right now. 3rd degree burn. If they have feeling to that body and they have blistering to their skin, that's actually a 2nd degree burn or a partial thickness burn. That's not a 1st degree burn, but we're either dealing with a 2nd degree burn, or a partial thickness, or a full thickness 3rd degree burn. Also, I would actually ask the patient if they can crawl over here and move over here, because I'm not comfortable putting my back against a spot like this. We also need to palpate neck and back, see if we need to apply a C-collar or a backboard on this patient. It is a significant trauma, so I think they'd be a great candidate for this. But we'd also consider life over limb, so I wouldn't really worry about the C-collar backboard till they crawl a little bit away from that spot. Which may seem contradictory to what I'm saying here. Come on, get in. Okay, biggest thing. Yes, we have all these different injuries. I want to see what's going on in their leg, right? We'll get a pulse ox here. And I don't think there's any harm in getting a blood pressure on their left arm, but let's just get it on their right arm for right now. It calls this a 3rd degree burn. I ain't calling this a 3rd degree burn. Can I expose the legs? Okay, vitals are all stable. Looks good. Can I look? I don't know. I don't know how to expose them. Can you let me look at their legs? I guess I'm just gonna guess. Okay, good. Okay, so I'm seeing here some, it looks almost like a blistered skin. I would be comfortable calling this a 2nd degree burn as well. Just because of the weird leaking tissue that's occurring here. I am going to put a burn dressing on this arm as well. And I'm going to call this a 2nd degree burn unless the patient can't feel this area anymore. Okay. Because it's blistered skin, we would expect kind of like a leathery skin for a 3rd degree burn, and that they can't feel around the specific area. We're going to do a dry sterile dressing. Okay. What else can I assess here? Unequip. Administer O2 mask. They're satting at 100%. I'm not doing that. Establish vascular access. I am going to do that. No, I'm not going to establish an IV in their leg. What the heck? Let's do it on the unaffected arm here. Okay. Oh, shoot. All right, I missed an IV. That's fine. And normally we'd apply a tourniquet, right? We'd apply a tourniquet. We'd have our flush with our saline lock already set up. We'd dispose of that sharps in the sharps container. Besides that, let's assess lung sounds too, just because it's a burn injury. And I couldn't hear any of that. I'm just going to assume it's fine. Airway checked. Can I tell how much pain my patient's experiencing? I wish you would say. I mean, the BP cuff could act as a temporary tourniquet. No, I wouldn't really consider it for that. I understand your reasoning, but I wouldn't do that personally. Just because I would more so focus on actual dressings. Let's see.
Don't delay transport. Let's go.
It's saying administer morphine. Unless I can tell what the patient's pain currently is, I'm not going to administer morphine. Although I do believe that it hurts, and I could see the argument for it. I ain't doing that. So this patient had a burn on their right forearm, as well as a burn on their left upper extremity. What would I do? I would actually use the rule of palms on this, because it was like, I would say, half of their right forearm and on the left upper thigh of their leg. And so I would give it a rule of palms, and I would say 4%. And I would say that on the radio. And I would say, Medic 72 to sponsor line, go ahead. Medic 72, I have a, how old is this guy? 26-year-old male patient who has a 3rd degree burn on his right forearm, approximately 2% total body surface area, and I screwed up the whole thing. Let me do it again. Medic 72 to Spawn Shoreline. Spawn Shoreline, go ahead. Medic 72, I'm coming in code 1 with a 26-year-old male patient. Current GCS is a 15. Patient was working with some electrical equipment whenever he got shocked. Has a second-degree burn on his right forearm, approximately 2% total body surface area, and a second-degree burn on his left upper thigh, approximately 3% total body surface area. Current vital signs are as follows. BP is 114/76. Heart rate is at 90 beats per minute. Satting at 100%, and temp is at 98.4 degrees Fahrenheit. ETA to facility in approximately 3 minutes. Right, and I'd be going code 1. So if I'm going code 1, I'm not crossing red lights. I'm stopping at every red light. Let me stop here, actually. I should not be doing this on the road, but it's a video game. And I'll be going right here. And it looks like there was actually a red light there. But I'd be using my signals, of course. I'd be following traffic. I'm not going to do that because it's a video game. Okay. Would that be a 9 on the burn scale? I wouldn't use it. Or I wouldn't describe it. Actually, so what do we know about the burn scale? The left leg is 18% for an adult. The right arm is 9% for the right arm. Because this is so subjective and there's such little burned total body surface area, I would actually use the rule of palms here. I think it's a great reason to use the rule of palms. You said, would that be a 9 on the burn scale of his left upper thigh, or a 4.5 since it's not the whole leg itself? Exactly right. So we're kind of splitting hairs here. I would use the rule of palms. I wouldn't use the rule of 9s. I don't think it's applicable for this scenario. And this is more so realistic of what you'd experience on scene. Okay, so we're heading to the hospital. Whoa. And generally, we're not using the Parklands formula. Although, I did fail to mention, we actually can consider normal saline administration. We can give anywhere from about like 250, 500 cc's of saline and we'd be fine. But I wouldn't use the Parklands burn formula unless the patient had a burn that was second or third degree burn and it was 10% or greater of their total body surface area. Have you used the HandEvi app? If so, what are your thoughts in the pre-hospital setting? I'm not familiar with it, although I'll save that and I'll look it up here in a moment. Let's put it right here. I'll check that out in a moment. Got questions. Do medics in the U.S. always give a pre-alert to the hospital? Yes, we do. We usually use Pulsera and we usually type it out. And also, let's say if I was doing the Parklands burn formula, and we'll just do some math here, right? Why not? How would I calculate it? Well, the way you calculate the Parklands burn formula, and this is more so for you guys to learn it, is 4 times total body surface area times weight in kilograms. So if the patient weighed, let's just estimate 220 pounds, we divide by 2.2. So it's 4 times total body surface area that's burned times their weight. So 100 kilograms. So 400 times, we said 4%, right? So we'll just call it as 4. So 1,600 is a total milliliters that they'll be administered during the next 24-hour period, which again is why we don't even consider something like that until we have at least 10% total body surface area that's burned. No, that's fine. However you calculate it, this is hard to do in the field, right? Or just in general. And for the Parklands burn formula, for the first 8 hours, we administer half the saline total administration. This is for you guys to learn. So it'd be 800 cc's over 8 hours, so 100 milliliters per hour. And then in the next 16 hours, we administer the other 800 cc's of saline cc's is just slang for milliliters, right? So we administer 50 mLs per hour at the hospital for the next 16 hours. And that's how we would utilize the Parkland's burn formula for a patient like this. And if they change their estimates, that's fine too. But this would be a great patient to at least administer prophylactically some saline administration. And we definitely would cover up this patient. It's fine for this transfer for this hospital staff. An A. Why'd I get an A? I missed visualizing the hot burn. I thought I visualized everything. A normal blood sugar, I can't assess the blood sugar yet. You don't let me. And the burn. Okay, so somehow I need to get better at assessing it. Administer morphine and O2, I disagree. Look, the blood sugar went from 81 to 71. That's interesting. I'm cool with that. I'll take the A, if that's what that means. My shift's still going? All right. Miss Johnson, let's see if we can get a second call.
This is dispatch.
A house fire! Whoa! That's cool. This game's cool. Even though there's a lot of issues with
A
it.
residential building is on fire and
Super
has been
cool.
reported. There might be more than one person in the building. Be prepared for smoke inhalation and burn victims.
Okay, so this is an awesome scenario. So we have maybe multiple patients that came from a house fire, may still be in the house fire. And so it's a residential regular, is what we call it for 911 service. They're dispatching engines. They're dispatching... it depends on what your service does, on if they're going to dispatch like a ladder truck, if they're going to dispatch regular engines, they're going to dispatch a battalion chief. They had multiple personnel possibly inside, so we're going to dispatch at the very minimum 2 medic units, but maybe more later depending on the scenario. We're worried about inhalation burns, right? We're worried about soot around the nostrils. We're worried about a potential narrowing airway, and so we need to consider RSI if we have it available, or rapid sequence intubation for paramedics. We need to consider knocking them down with something like etomidate. We use maybe succinylcholine or something as your induction agent, or roconium. And then if we do roconium, we're doing RSI, then we need to go ahead and follow it up with something like midazolam or something. Some agencies will use ketamine for their sedative, although I'm very unfamiliar with it. And then we'll need to, of course, establish that advanced airway like an endotracheal tube. If we fail to do that, we'll at least need to put in a supraglottic airway, or bag the patient at least. And just go from there. But that's super cool.
Transmitting location.
Right, we're worrying about their airway being exposed to superheated gases, and we're worried about it potentially narrowing and closing up. I've had a patient that was exposed to a superheated gases where I didn't have RSI protocols, and I saw them literally going out of consciousness from their airway closing. And even though you're not supposed to, I personally gave them epinephrine, and it opened up their airway, and the patient survived. So I've had a good scenario with this. But I gave the epi-IM, even though I had an IV set up, because it's different for the administration route and the dosaging. Alex, you're going to head out. I hope you have a good day. I hope you have a great day, too. And Hentevi, it's an Aussie ambulance service app. That's pretty cool. I'll have to take a look at it later. It was good to see you, Alice. This is cool. All right, we already have multiple engines on scene. Normally somebody would be at the very least, they're all EMT-Bs, but they may be paramedics also, depending on your service that you work with. They would be giving me pass off at this time, telling me what's going on. I'm turning off my sirens here. I'd probably pull up right here, maybe even a little bit out of the way in case you need an additional unit. This looks like it's a bad call. Let's go to the most critical looking patient right here.
Got pain in my right.
Pain in right leg. How can I be of assistance?
It burns so bad.
It burns so bad I can't look down at it.
But why can't I feel it?
They can't feel their
I'm
leg.
supposed to
That's
feel
huge.
it. Am I
We're
not?
looking at a 3rd degree burn, full thickness burn.
I have no idea. was asleep when something burning.
And
woke me
they
up.
could possibly have narrowing
The
airway.
whole room was on fire. I will do what I can.
Stay calm. This is a red tag patient for sure. This is a
I was
critical
so
patient.
lucky. Now look at me.
Poor guy.
I'm lacking sleep, but it's nothing to worry about.
Okay, so we're worried about a 3rd degree burn. We're also worried about a, let's see, let's do an assessment. About airway collapse. Inflamed skin, very bad. This is my patient. This is my most critical patient I can already possibly tell. Painless burn, really bad. Any other supporting factors? No? What is your name? Triage patient. You're getting a red, Rocco. You're the guy I'm going to take to the hospital if I have to take the most critical, which shouldn't normally be the case. Okay, what's going on here?
Right lower leg.
Critical life bleed, that's also really bad.
My skin feels like it's still in the flames.
Really bad.
I don't know how the fire started. But when I noticed the flames, I started to look if there were other people in the building.
You're a hero. That's great of you to do that, but I hope you're okay.
I know, but I can't let the others die.
Oh my gosh, she's a hero. She's a hero, what
No
the heck?
issues that I know of.
I want to save her now.
Nothing prescribed, just some headache pills.
She's running in, making sure everyone's out of the fire.
That feels better.
Okay, let's take a look at you. Strong bleeding, bloodstream. I actually think you're more severe than that other patient too. Just because if you don't control that bleeding, you're going to bleed out and die. You also get a red tag. What's going on with you?
Chest, stomach. I'm just in a lot of pain.
What's going on? Chest pain, not good. Trouble breathing. I breathed in too much smoke. Oh, you're all red tags.
Breathed in too much smoke.
You are in a horrible state too.
Had an incense stick burning. But I doubt it caused the fire.
She's also the reason why the
I
fire
ran out of the
started.
building as soon
It's
as
okay,
I saw
miss.
the
I don't
fire.
hold it against you.
Am I a coward?
No. You're not a coward.
I just saved myself and ran.
No. That's okay. I'm gonna tell the patient it seems like you got away with just a black eye compared to your mates. What the heck? No.
Lighting incense helps alleviate my headaches.
I would never tell a patient that. I would only support them. And I'm not the police, so I don't care about who caused the fire. This is bad. She's about to die.
Feel better.
She's about to die from inflamed airway. He's actually my least critical patient now. She has become my most critical patient because of airway. Although I do need to address the bleeding from that other patient. Difficulty breathing, red inflamed skin. Looks like she has multiple burns on her body. Okay, you are getting triaged as a red tag. Can I just give you like a bandage and then leave you alone? Other patients? You're a witness?
I saw nothing like that.
Okay. I need you to move out of my way. What's going on with you?
It hurts to the core of my body.
What the heck? Alright, what's going on? We can already see blistering of skin.
Tight. I think
Chest feels
I
tight,
inhaled
inhaled too much smoke. Disaster.
I lit up some candles for aromatherapy. Then this happened. They didn't cause this. I immediately fled the building when I saw the flames.
Okay? I don't need to be telling a patient this. You're not a
Am I
coward. You're not a coward.
Coward.
It's okay if you didn't save them.
I just saved myself and ran.
I would never say that. I should stop clicking the unusuals.
Heavily
Safe.
scented candles are my preferred method of treating headaches.
Do you take any medications?
I don't have faith in modern medicine.
Well, you're about to get a lot of medicine.
That feels better.
Okay. Assess. Smoke inhalation. Difficulty breathing. Red blistering skin. That's not good. Run. Oh, I need to triage you. Run. E. You're a red tag. Go, 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 go. Who are you? Why is there so
Chest,
many patients?
Stomach? I'm just in a lot of pain.
We need to move this patient away from the fire.
My skin still feels like it's in the flames. My skin feels like it's still in the flames.
Okay, you told me that already.
I don't know how the fire started, but when I noticed the flames, I started to look if there were other people in the building.
He's a hero. I don't need to tell
No
patients
issues
that.
that I
I'm
know of.
skipping that QTE for now on.
Over here.
Nothing prescribed, just some headache pills.
Fire would never have all these patients laid out like this, by the way.
Feels better.
This is ridiculous. Okay, scan, scan, scan. Inflamed skin. How's your chest? Scan, 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 scan. Strong bleeding. That's bad. But I don't see smoke inhalation. You're at a lower priority for me. You're gonna get a red tag though. Yes, it's dangerous.
Just.
Although I can see the argument for a yellow tag as long as we
I'm
can
just
control
in
the
a lot
bleeding.
of pain. I'm
Having trouble breathing? Oh my gosh,
Trouble
red tag
breathing.
again. Everybody's getting a red tag.
I breathed in too much smoke. I had an incense.
Everybody has things burning in a house.
But I doubt it caused the fire. I ran out of the building as soon as I saw the fire.
Okay, I'm not gonna tell people the unusual scene. That's rude.
I find that lighting incense helps alleviate my headaches. No, I don't think modern
Nobody here
medicine
believes medicine is
trustworthy.
realistic or useful. That's okay.
I'm starting to feel better.
Oh, awesome, miss. Let's take a look at you. Scan, 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 scan. Smoke inhalation, difficulty breathing. Inflamed skin, red skin. You get a red tag. Okay, so we have all these patients here. I would try to tell fire to get some of those people away from the burning building. Now, what's really interesting, I think I'm saving. You had the trouble breathing, right? You had the trouble breathing. Here's the interesting scenario to this call, right? We have multiple patients who are experiencing the same thing. So who do we respond to? Let's see. Gotta head out, sign up for overtime today. Enjoyed watching chatting. You should do more live streams with medical games like this. Very fun to watch. Yeah, this is interesting. I've never seen a game like this before. But it's great to us. Well, it was good to see you. Great power rate. I appreciate you being here. And it's great for us while we're en route. We can input a rough estimate of the patient. That's pretty cool in regards to the emergency call we can calculate based on our protocols. Yeah, I think NSW ambulance just decided to use an in-house built app. Absolutely love the med calculators and checklists. That's very cool. We don't have that in Annabelle. Okay, if we have multiple patients complaining of the same thing, we need to just pick a patient that's similar. Can I leave the stretcher for a moment? All my patients have red tags. Hemorrhagic emergency, venous bleeding. You, difficult respiratory emergency, that's horrible. Environmental emergency, burns 3rd degree, it's fine. Via smoke inhalation, so I would pick respiratory, honestly. Okay, go, 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 go. I don't know if I actually even need to be doing this. No. Okay. And then I'd pick a patient who has a respiratory issue. So I'd actually go around him because he didn't have a respiratory injury. I think she had a respiratory injury, if I remember properly. Miss, I'm picking you. And this is the life over limb. I don't have an issue with putting them on a, just throwing them up on the stretcher. We need to get them going. Go, go, go. And if I'm the first ambulance on scene, I'm not going to be leaving any of these patients. Although you can if they have a medic on scene and they have a paramedic that's on scene as well, then it's fine. Okay, what's going on here? Let's get a BP on you. Okay, let's assess your vitals. Let's get a pulse ox on you too. We're going to do the same arm because she has an affected right arm. What else are we going to do? We're going to take a look at their lung sound, see if it's closing up. Okay.
I feel like the room.
Check for breathing issues. I'm going to bandage with a dry sterile dressing. Move over. I would also expose the legs too, even though it doesn't let me do that here. I need to see everything that's going on. Okay, I disagree. They try to make it into a game by doing stuff like this. Oh, hypotension. Let's see. I agree. This game's so cool, and I agree with it because it considers blood pressure less than 100, 100 systolic as hypotensive. Technically, national standards, actually, I'm kind of leaning more towards like 90 and less than 90 is hypotensive. But the way I teach it is if you have a patient whose systolic is less than 100, then I consider it hypotensive. This game agrees with me too. Awesome. I'm glad we're such like-minded folk. And even if their blood pressure would be normal in the national standards, I would give saline also to this patient. Let's do the unaffected side, right? So we can establish an IV here, it's fine. This would be a great patient to give normal saline to. So we're establishing an IV. We wouldn't do a 22 gauge, we would do a 18 gauge or a 20 gauge if possible. We're also going to give him some normal saline here. Okay, and we don't administer saline like this. We would administer bolus. We would administer about 500 to 1,000 cc's of saline via like an IV drip. We're not administering that as so. Administer an O2 mask. I'm not doing that. If I had RSI protocols, these patients with burn inhalations would be great people to consider it with. But I'm okay with this. Because they're having a burn inhalation, I'm going code 3. Their airway is going to close up at any moment, and I don't want it to happen while they're in my box. Go, 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 go. Go, 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 go. Go, 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 go. Also, they're setting at 96%. It's in the normal range. I'm not going to put oxygen on a patient for fun. So I am of the scope or of the mindset where I'm not administering O2 administration. Although some people could argue that you're doing it to displace any possible carbon monoxide. And I'm cool with that. I followed my GPS. Where's the okay, the hospital is here. I'm cool if you administer oxygen for a patient like this. And look, their sats are actually dropping now. But I personally wouldn't have initially. Go, 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 go.
Let me see.
Although I can see the argument for it. Maybe I should have given oxygen for this patient, right? An S! I got my first S tier. Yes! Finally! Oh man, that has been a long time coming. And let's end the shift. This shift has lasted too long. An A for the occupational hazard, an S for the house fire. I've leveled up as a medic. You have unlocked a new catastrophe or catastrophic event. The freeway catastrophe. New catastrophe event unlocked. Select the catastrophic event to play it. Cool. I've unlocked 30-minute shift and gunshot call out. Whoa, internal bleeding shock, freeway catastrophe. We've got to do another poll. We've got to start a poll here. Which should we do next? I mean, I know what I want to see. Regular shift, catastrophic event. What else? Training panic attack. Training arterial. That's pretty cool. What are you guys thinking? Yeah, it's a cool one, right? Catastrophic event? I think it's going to be... Bro, the regular shifts, they've got me triaging like 10 patients. That's so hard to do. How bad can a catastrophic event be? I'm cool with running with it, but you guys better expect a pretty tough call. So far, it looks like it's up for a catastrophic event. This is hard, man. But yes, I agree, CJ. So good to see you, CJ Foxy boy. I think we're gonna have to go with catastrophic event here. What are some of the votes for it? The training arterial bleed, I can respect it. I definitely can. We may do that after this catastrophic event. Let's end the poll here. Okay. Someone must have said the Q word before that regular shift. What is the Q word? What is the Q word? Quiet. I can already tell what the Q word is. Look at how scary it looks. I'm ready. Quiet, yeah. A collapsed highway. Oh my, this is going to be such a pain. A collapsed highway has caused multiple vehicle pileups, leaving many trapped and injured. Triage and treat patients on site. Race against the clock to prevent further fatalities. Oh, brother. Large-scale emergencies with mass treating patients, no other call-outs. Two-phase triage, time-limited, and treatment phase. Patients may die if not correctly treated. Hitting pedestrians will cause game over unless blah blah. Let's do it. I ain't scared. But now we think about crush injuries, and depending on your protocols, sometimes you may call medical control to consider administration of sodium bicarb with the lactic acid that builds up. Let's see.
Alarm for ambulance 152. Get
It depends
ready.
if they're trapped for hours.
Dispatch to ambulance 152. Come in. Over.
Ambulance 152.
This game is crazy.
Received a report of a major incident, possible highway bridge collapse causing traffic accident.
That's what I like to hear.
Situation unclear, but we're on high alert. Need you at the scene ASAP to assess and report on casualties.
You've called the right man.
Additional units en route. Stay tuned for updates.
Get out of my
over.
way.
Understood. Heading to the scene.
This is like the call of the lifetime. Don't forget the Hyper K. What is Hyper K
Should
for?
be fine.
What am I tripping on? Hyperkalemia? We consider that for a burn patient. Go, 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 go! Brother! Did you guys see the intro to the call? A mist of flames in the background? I'm in trouble. Look at this! For Crush, though, I'm unfamiliar with Hyper K for crush injuries. Are you just talking about electrolyte imbalances? What is this? I would honestly, if this was real life, I'm parking back here. I wouldn't even go into this scene. It's too dangerous. What the heck happened? How am I supposed to... Oh! How am I supposed to fix this? What the heck? There's like 40 patients! This is a catastrophe. I'm going right in.
All right, everyone, listen up. Here's the stuff you need to know in a situation like this. A quick sweep for initial patient assessment is key.
Black tag. Okay, sure.
Mark patients with the appropriate triage tag based on how urgently they need help. Remember, we can't save everyone.
This is so cool.
Stick to life-saving measures only. No time for complex procedures. Spending too much time on one could cost others their lives.
My left lower leg.
Keep
it's
yourself
painful.
safe first. People depend on you for a swift and accurate assessment, so your backup
You're
knows
minor.
what to do once
Get out of
they
here.
arrive at the scene.
This is so cool. This is so cool. Run, 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 run,
We
run,
meet
run,
back
run.
at the initial meeting point
Wow.
after
Look,
triage.
exposed brain matter. That is a
That's
black
what
tag.
sort out resources for treatment. No more chit-chat, time to move. Let's go.
Let's go. Patient is losing blood. Strong bleeding. Hematoma. Okay. Treat them. Tourniquet. This is the coolest game ever. This is the coolest game ever.
My left lower leg, it's painful.
Calm down.
That feels better.
Your left lower leg, can I see it? You're gonna get a yellow tag. Delayed. Sure. Go, go, go. What the heck happened to you? Oh my gosh, red tagged. Go, 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 go. Rapid eye movement. She's got everything wrong with her. She's stuck in the vehicle. Treatment. You get a tourniquet. Tourniquet. Lymph flow stopped. You get triage. You're red. Go, 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 go. Black tag. Wow, that's crazy. That is a crazy call. Go. Oh, okay. Burning hurts me. Go, 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 go. How am I going to sweep the whole... I'm going to hug on the right side. I shouldn't be in here right now. This scene is too dangerous. Yeah, I should have patients escorted to me. However, for the sake of this call, this is fine. Black tag. What's going on with you? Rattling sound, coughing, obese? I don't think she's obese. Difficulty breathing? Red tag. You're getting red tagged. Can you talk to me?
Stomach.
A lot of pain?
I'm just in a lot of pain. This cough won't stop.
This is crazy. Okay. What can I do to help you? I have epi administration. I just haven't unlocked it yet. I'm sorry, miss. Looks like you got a bleed on your left arm. I'm not messing with, or right, left arm. Yeah. I'm not bleeding with or messing with it right now. You are immediate because your airway's gonna collapse. You're gonna die. Go, 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 go. Black tag. I agree. Black tag. This game is so good. Hello, sir. What's going on with you? Assess, scan, 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 scan. Oh, don't worry about it, the revolution. I shouldn't be reading your stuff at the same time, right? But I don't blame you at all for that. Talk to me.
Pain in my right
Pain in your right
thigh.
thigh? How bad is it?
My skin feels incredibly warm.
Okay. Pain in right leg? Doesn't look like he's actively bleeding. I'm cool with you. I don't care about you. I need to triage you, though. I don't know if he's going to transition to a red tag later, so we're going to put yellow tag for right now. Go, 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 go. Anyone in the vehicle? Go, 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 go. That's how my mind would be working, by the way. Go, 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 go. What's going on with you? Spurting blood? This is a perfect time for a tourniquet. Okay.
Left
No. I don't care about this. Get me out of here. Get me out of here. Treatment. Spurting blood. Spurting blood. Okay, now, I just put a tourniquet on you. You got spurting blood in your leg too? Oh, brother. Oh, good, I can see you perfectly now. Triage, red tagged. We got dual tourniquets on this guy. That's crazy. Go, 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 go. Go, 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 go. Another patient. Patient is losing blood. No, don't lose blood. Rapid eye movement. What treatments can I do for someone who's just losing blood? Because it's on their stomach. I have to pack, or I have to seal it. I can't do anything for you, buddy. This game won't let me. You're immediate. You're going to bleed out. Some Flintstone vitamins? Good thinking. Go, 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 go. Oh, I can't triage you yet.
Head's hurting.
Head's hurting? Okay.
I have a really
That's not good.
dark
That's not good.
bruise.
Okay. Scan them, scan them. Go, go. Patient is losing blood. Looks like she's bleeding from everywhere. Strong bleeding. Okay, if she has... Hold on. Immediate treatment. Tourniquet. Sure, let's just throw a tourniquet there. Why not? Treatment. I have unlimited tourniquets. You're getting tourniquets everywhere, miss. Treatment. Tourniquet. You're gonna look crazy right now, but I think that this is the right move. Okay. Go, 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 go. How are you doing? Underweight. That's okay. She's malnourished. That's okay, miss. You're okay. Did I already triage this lady? I did. Strong bleeding. Underweight. Okay. Triage. You're getting... You have a hematoma? You're yellow tagged. I think I'm tripping out of here. Okay, what's going on here? Go, 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 go. We're hugging around the right side, right? We're trying to do some type of uniform search for every patient. You. Squirting blood. Not good. Not good. Okay. Treatment. Tourniquet. Put it above the injury. Anything else? No? Okay, triage. Immediate. Go, 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 go. Go, 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 go. We're not talking to anybody anymore. There's no time. Okay, let's hug around this side first. Any patients that I'm missing? You vomited? Okay, I don't care if you vomited. Gray skin? You're a red tag. Okay. Treatment. Tourniquet. Apply tourniquet. This would be a insane call. I don't think I've ever had a call this tricky in my life. No, I haven't. What am I saying? But it's okay. That's why we train. Triage. You get a red tag. Okay. Okay. Go, 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 go. Did I already triage you? You're black tag. I don't think I got on this side. I'm running out of time. You. Hematoma? Grabbing his head? Obese. Buddy, you're getting a delayed tag. You're getting yellow tagged. You. What's going on with you? Scan, 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 scan. This is probably going to be the last patient I can hit in 10 minutes. Hematoma? You're getting yellow tagged. Go, 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 go. Go, go, go. Oh my gosh, there's... you're red tagged. Or black tagged. You, I can't reach that guy. I'm just going to black tag you and be done. Black tag. Okay, you're black tagged. I didn't get to go to this person.
Dispatch to all units. Situation is under control, thanks to your efforts.
Oh, okay.
Reinforcements and a field hospital are now operational. Green priority patients have been evacuated. Your mission, locate and stabilize urgent cases still unattended in our field hospital. Resources are stretched, but you've been supplied with your standard treatment equipment.
This is really cool. Okay.
Work swiftly. Many lives are still on the line. Over.
This is super cool. Treatment.
My right upper arm hurts.
Your right upper arm hurts? I believe it, buddy. Let's get... I need a BP on you. This is on his left arm, that's fine. The right arm is the affected side, so leave it alone. I don't have access to blood glucose, which is criminal. He was in a burn, so I need to assess lung sounds. Look, he's got a
Temperature is
second
going
degree
down.
possible burn
We're
right there
back to
too.
normal.
Trauma dressing. Start. Go, 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 go. How do I make this faster? Beautiful. And we're gonna put, I would honestly put a dry sterile dressing for something like this. You could consider a moist sterile dressing because it's the abdomen, but unless I see protruding abdominal organs, I'm not gonna do that. Okay, I'll put a dry sterile dressing here too. Perfect. Okay, vitals look fairly stable. I'm going to leave you alone for now, buddy. I don't know what your name is. How do I get out of here? So treatment. Your name is John Doe. Can I assess you? No? How do I tell which one this is? I'll say environmental hazard. That's fine. That's fine. You're good with does that. We need to keep going though. We have a second
Left
patient here. He's
upper
grabbing his
arm's hurting.
left upper arm with the laceration. Okay, that's pretty serious. Let's see. BP
My
cuff.
heart,
Here we go.
help me! Oh, damn. My heart won't stop. My heart, help me!
Okay, let's get something else. We're getting a baseline set of vitals on this patient.
Damn, my heart won't stop.
He's
My heart,
tachycardic. He
help
has
me.
SVT right now. It's not good. We need to bandage this area. Okay. Some people would argue that you should put a tourniquet on for something like this. Oh, he already does have a tourniquet on. That's fine.
It's getting hot.
Pressure dressings can work for arterial bleeds first. So at first you do direct pressure, then you go from there. You definitely would bandage the area though. Blood loss restricted. Okay. Looks like it worked. For a patient like this, he's in a severe amount of pain. It's probably why his heart rate is the way it is. Although I'd like a 12 lead EKG to see what's going on. I assume that it's caused from hypovolemia, so I am going to give this patient some saline. Go, 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 go. I would not be injecting it into him. I would give him like
Are
a
you
1,000
preparing
cc bag.
surgery? Just drive.
Okay, you don't need to be rude to me. And I actually think that morphine administration would be fine, but we have to reassess him if we do it. Okay. He's probably in a ton of pain right now. Let's give him some morphine. I think it'll be fine. And we can do some Zofran also. But if we give him morphine, we need to reassess his blood pressure. Okay. Let's go back on the left side. Am I just going to get vital signs throughout the whole call? It's fine. I'm sure you'll show me later. You're going to stay as is. Treatment. Let's get a blood pressure on you. On the other arm. You know, Miss Johnson is a paramedic. So her not doing anything shows a lot about her. About her actual character. Blood pressure cuff.
Are you preparing surgery? Just drive.
Don't it, Miss Johnson. Stop insulting me, Miss Johnson. I've got a really big caseload right now.
Blood pressure is normalizing.
Okay. It looks like she has bleeding that's rolling out from here. Let's go ahead and bandage this patient. Perfect. We always apply direct pressure and a bandage before we go with the tourniquet. Although I know why they did the initial tourniquet.
Blood
It's fine.
pressure is getting too high.
Chill out. Blood pressure's at 140. Okay, it's fine. Okay, bandaging up these areas. That's fine.
Are you preparing surgery?
You
Just
stop
drive.
it insulting me. Blood pressure's getting too high. You know what
It's
I can do
getting
for a patient
hard
like this?
to breathe.
Okay, who said it's getting hard to breathe? I didn't check lung sounds on the last guy. That's not good. I would have done more, so anterior, that's fine. Okay, and let's go ahead and start an IV. We can do it on this arm, that's fine.
I'm having trouble
And you get morphine.
catching my breath.
Congratulations, you get morphine. And I would reassess the vital signs, right? I'd reassess that one guy's vital sign as well. Okay, this is this patient. Hemorrhagic emergency.
We
Venous
are
bleeding.
done here. Hospital, now.
Miss, I was told to triage these patients. His heart rate's going so high. That's a disaster. He's satting. He's desatting. All right, let's go ahead and throw him on an oxygen. Oh, we need to administer something like adenosine for this patient. But we need to see a 12 lead first to see what's going on. Do I have access to adenosine? I don't. Alright, well, he's got oxygen at least. I still have to assess the other patients. That guy is dying, though. No reaction, blue skin, unresponsive? Is he dead? What's going on here? I can't just check a pulse.
We are done here. Hospital, now.
Miss Johnson, this guy has gray skin. Stop talking to me. He probably needs oxygen. He does. You see, sometimes you got to ignore your partner. I have access to a ventilator. A ventilator can supply a non-breathing patient with oxygen automatically. Normally, I wouldn't put a patient on a ventilator. Do I have access to RSI protocols without RSIing them? There's no response with this patient. I would never leave them alone. I don't know if this is allowed. They are unconscious and their airway is failing. The issue if I administer this to a real-life patient is we'd have to bag them the entire time.
We are done here.
You're getting this for right now.
Hospital, now.
I can't leave you alone, and my crazy partner, I don't think that she's going to bag you. I'm just going to be honest. She doesn't give me that kind of vibe. Miss, what's going on with you? I need a baseline set of vitals. Let's get a blood pressure. No. Let's get a pulse ox.
Blood pressure is normalizing.
Thank you, Miss Johnson. I wouldn't personally do this at this time because I need to just take care of that grayish patient. But you know what? Let's stabilize him and get going. That patient needs to be RSI'd. That one who's gray and mottled. Or actually, he doesn't even need to be RSI'd. We just need to establish a ET tube on him and take care of him the whole time.
We are done here. Hospital, now. Blood pressure is getting too high.
Sometimes you just gotta ignore her. Perfect. Okay, respiratory, smoke inhalation, I'm cool with it. Can I assess your lung sounds too? Let's see. Okay, we're getting out of here. We've assessed all of them. How's my patient doing? We need the stretcher for this patient. He's got to go. How do I assess him? Cardiac emergency. Not cardiac
We are
arrest, sorry,
done
shock.
here. Hospital, now!
This patient needs... I mean, I would be cool with doing RSIing as long as my partner is ready to monitor the patient the whole time. Let's see what this game does. Okay, it's just hooked up to that. I'm cool with it. You know what? That's gonna be the patient we're gonna transport. This guy cannot be doing good. This guy also, is he responsive? No reaction? Guess what? You get something too. You get an ET tube as well. If you're not responsive, this is a disaster. Intubating 2 patients and not monitoring either one. I think I gave him pain management too, which would just be a disaster for this patient. Okay. How are you setting it right now? You're improving. All right. So I think I gave him morphine earlier, even though he was not responsive. That's a horrible idea. But it's okay. I'm okay with your blood pressure being like that. We're gonna take, which one? You're improving. You're improving, but you're pretty low still. We're gonna take you. And then you need more saline, but we'll leave you alone for now. End treatment phase. How do I end it? Okay, that was tough. That was very tough. I gave him morphine even though he was unresponsive. That doesn't make any sense. I thought he was responsive. Select a patient and drive them to the hospital. Okay, I know who I'm going to transport already. Leave stretcher. Why are you red tagged? I'm taking you. I don't care what the game says. If you're intubated, you are my critical patient. We would never want to administer an intubation on a patient and leave them alone, by the way. That's crazy.
Dispatch to all units, on-scene stabilization complete. Be ready to transfer any critical patients assigned to you to one of the surrounding hospitals.
Okay.
Be advised, assignments may shift en route due to live updates on hospital capacity. Prepare for likely health complications encountered during transit. Ensure everyone's safe and swift transition into clinical treatment. Dispatch out.
Okay, this was a very hard call. There was like 20 plus people to triage.
Our patient doesn't like that at all.
His heart rate and his SpO2 is not good. I have him intubated right now, so it should be improving. As long as you need to bag a little bit better. He also may have some bleeding built up. Maybe we need to consider assessing both of his lung sounds, and do we need like a needle decompression or something? Looks like his SpO2 is improving with my partner though.
Patient's running out of time.
Okay, he should be intubated and being BVM'd right now. That's fine that he has a non-rebreather on him initially. I think maybe he was conscious and then went unconscious. A B? Oh my gosh. Missed patient? I can't help it. Triage score -140. 80% patients located. Wrong life-saving intervention. I'm cool with that. Coughing, can't talk. Difficulty breathing, wrong guy, wheezing. Okay. I just swapped it to hemorrhagic. Shock, I guess. Oh, I didn't properly categorize them. Okay. I don't understand how I'm missing these. I have to figure out how to assess better, I guess. Was it 145 now? This time it's at 8. Okay. That was the catastrophe event. That was really hard. What are they saying here? I got to read this. First glucose was at 145. Oh, poor sweetheart. Okay, anyway. That was the catastrophe event. That was extremely hard. Okay, let's end the shift here. We could definitely have room for improvements, Miss Johnson. I appreciate all your help. I don't appreciate her rushing me, but that's okay. A B? Golly. Congratulations, paramedic. You have unlocked the injured homeless person call out, a glucometer, glucose, and insulin. We would never administer insulin in the field, so I'm pretty against that idea. The glucometer, though, is huge, and glucose is huge, although I would consider it as dextrose. A little weird. Whew. District progress, 5 out of 7. Okay, let's do arterial bleeding. I said I would do arterial bleeding, so we need to hop into it. This is tough.
Welcome to St. Johann. I will be your partner.
Oh, Mr. Davis. I kind of like Miss Johnson.
I have heard a lot of good things about you, but be aware, things are quite different in this district.
Okay, thanks, Mr. Davis.
Dispatch to ambulance 152. Gunshots reported in an alley in St. Johannes. One person injured and bleeding.
Okay, so we have a gunshot patient. I mean, unless it's an arterial bleed, which I know this specific one is, then I personally, our gunshot calls are usually pretty easy. Take any shortcuts you can. Thank you, Mr. Davis. Usually, gunshot patients, a lot of times they're stable, right? You're looking for the, where they were shot at, the entrance wound as well as the exit wound. Of course, we're considering things like pulse motor sensation. If they maintain that during the entire call, and every time we bandage it, if we do bandage it. And we want to know the caliber of the bullet. And also, is this scene safe? That's the most important thing. We have PD on scene. If not, I shouldn't even be approaching this call. Go, 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 go. Okay, and if the scene wasn't safe, I would be parked a little farther away, but it's fine.
This should be it. Let's take a look at the patient.
Okay, I see the patient. Alright, what's going on with this patient here?
Looks like arterial
I
bleeding.
injured my right lower leg.
Select the tourniquet from your tool bag and use it to limit blood flow to the hemorrhaging limb.
To the left leg? Okay, rapid assessment, that looks fine. Open tourniquet, no. Okay, we have an obvious spurting of the leg, but it's on the right leg even though he said the left.
This should buy us some time. Some patients require immediate action on site. You can read up on life-saving measures in your handbook later.
Did you see what happened?
For now, hurry and get the stretcher. We should continue
No,
treatment
I
inside
only
the
heard the
ambulance.
gunshots
Time is
and
critical.
found them like this.
Okay.
Then I called emergency services.
Great job, Monsieur Hero. I need to get some general assessment on this patient now, too.
I have a really dark bruise.
Okay.
Blur. It all hurts.
Okay, do you suffer from any
I
health
haven't
issues?
had any chronic illnesses. No, I haven't taken any medicine.
And please stay calm. We'll take good care of
Starting to
you.
feel
Okay, this is a really serious injury, right? We need to consider using a backboard C-collar on this patient. Can I apply a C-collar on this patient anyway? I don't know. I won't put a C-collar on her, but I think that it's a good idea if you consider that. Let's get the stretcher out of here. Let's get the patient loaded up. Then let's throw him in the back here. Okay, that looks fine. Alright, let's see here. So the first thing that we always need, I would normally prefer to get a baseline set of vitals on the floor, but if we get it while we're in the ambulance, that's okay.
We should do our best to raise their blood pressure again.
Okay, I'm okay with that.
Once you are done bandaging the patient, use the IV needle to gain vascular access and attach the saline solution afterwards.
Okay, I'm cool with that. We'll administer a BP cuff and then saline solution. I'm not administering saline solution for a BP at 114/76. Or I can consider it actually. I'm not against that. Let's bandage the patient though.
Temperature's going down. We're back to normal.
Okay, that's good. Okay, quick, play the bandaging mini game real quick on your patient. Perfect. I don't think I need to bandage that area. I think it's fine. Let's listen to lung sounds. I don't have access to it. Okay. And we'll start an IV. Again, we're going to use an 18 or 20 gauge IV. I disagree with the choice of 22 gauge here, but that's fine. And I can administer some saline. Perfect. Okay, we have 2 injuries on the side. Bandage bleeding wounds. I already did. I can bandage these wounds too, although I don't really think it's necessary. In real life, I wouldn't waste my time bandaging these wounds. I would leave them open so the ER staff can see. And if I did bandage anything, it would be more of an open wound like the one on the right leg.
The patient's temperature is dropping. Let's warm them up.
Oh, wow. Okay, I didn't even see their temperature. Their temperature right now is at 94.9. That's really cool. So they are reaching that hypothermic state. Okay, I really wish I wasn't wasting my time on this. Okay. Okay. I'm about to delete or disable the bandaging minigame if I keep missing it. Let's do some active rewarming on this
blood
patient.
pressure is slowly improving. However, the patient is still in a lot of pain. We should do something about that. Pain management
I
is
want
an
to
important
address
part of
the
our job
temperature,
as well.
please.
We should put in another IV needle and administer some morphine. You can read up on pain management and the risks that come with different medications in your handbook.
Okay, so they're saying do a second IV. Since the first one has saline, I disagree with this completely, but we'll do it for the game, whatever. I need to adjust this low temperature, though. That's a disaster. Okay, I would not be giving this patient morphine right now. I don't think that's a good idea. But...
Well done.
Okay.
Patient seems responsive now. I think they got lucky in that no vital organs were hit.
Okay, can I
You should
address the
still hurry to
temperature?
the next hospital as soon as you're ready.
The temperature? The temperature, please? She is freezing? Okay, can I put a blanket on this patient? Blanket. Blanket. Blood sugar's at 83. It's within the normal range. I'm happy with that. Is there anything else I can do for you? I can really increase the temperature here. Let's make it a chill 81 degrees in the box. I think you'll be fine with that. Normally I would go up to like 74, 76 for the temperature. I would just be focusing on covering them up. Or what you can do is you can just turn off the AC, and that's fine too for the patient. You're going to sweat a lot, but that's just part of the job. And with the temp at 94.1, you know, I would actually consider going code 3 for something like that. With the gunshot wound and a temp like that, their body's failing quickly. And 94.1 is a fairly serious temp to have recorded. Okay, we're pulling in here. I've increased the temperature, but I'm unsure if the game wanted me to go even higher with that.
Let me see.
Skip the cutscene.
We take.
Good job today. Things got quite complicated there, but
Thank
you handled
you.
yourself pretty well. I'm looking forward to our next training session together.
I'd want a temperature at least between like 96.8 to 98.9. Show results. Freezes. How do I assess them further for that? Feeling nauseous? How do I get that? The gun or the proper clothes? Administer O2 mask? I'm not doing that. Lesser setting, less than 100%. I'm not going to do that. Cool. Some good arterial training. Let's get out of here. Okay, fantastic. Now, let's see. Do we do a panic attack or a regular shift? That's the next question. Which one next? Regular shift or panic attack? Both are such great choices. I could knock out the last of the training and do the panic attack, although it's probably going to tell me to administer lorazepam or Ativan in the field, and I'm not really a big fan of that. Excuse me. I could go for the panic attack, I guess. Regular shift? Brother, I'm cool with a regular shift. I think a panic attack is going to be lame. Let's just do the regular shift then. Okay. Let's hop into it. See what we have going on next. I need to take off my sweater for this.
Alarm for ambulance 152. Get ready.
Okay, let's see what's going on here.
Ambulance 152, high priority. Dispatch, acknowledge, over. We've got a report for a person in need of help close to some offices. The person is described as having
Okay, an anxiety
anxiety
attack, I call it
attacks.
anyway.
Location sent. Move quickly. Over.
It's a shame they don't have access to medications like TXA or something else, but that's okay. Go, 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 go. Go, 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 go. You do have some people. You won't have drivers that'll cross over like medians like this, but you'll have pretty crazy drivers sometimes. And as a medic, it's your responsibility to tell, like, hey, you need to slow down. We're not going to save any. We're going to a call who's with a patient who's possibly just having a panic attack. Do we really need to be driving this reckless? And the answer is always going to be no. Go, 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 go. However, at the same time, even though we're getting a 911 call to a panic attack, there's a chance that whenever we show up, it could be a lot more critical than that. I've had it before where I've had blood in a Foley catheter and the patient's in the middle of like cardiac arrest and nobody has recognized that. So, you know, you have to make your own assessment once you get on scene. Okay, we'll pull up here. Let's see what's going on here. So my patient seems afraid, restless. Looks confused. Okay, so we need to find out if they are ANO times 4 or not.
It hurts everywhere.
It hurts everywhere? Are they having chest pain or something? What's going on?
I don't know. I can't.
Okay,
breathe.
this could actually be just a panic attack.
I just left work. I'm not sure.
And they
what
left
happened
work when
next.
it happened?
No, this was the first.
This is the first time this has happened. Maybe something bad
What's wrong
happened, like
with
their
me?
loved one passed away, or they had some type of like
haven't
they
had
got
any
fired from their
chronic
job
illnesses.
or something. We don't know.
I haven't started taking anxiety pills yet, but I'm
Okay, so
thinking
he's had
about it.
issues with anxiety in the past.
I'm starting to feel better.
Okay, can we assess anything on scene here? We have a bystander here. Maybe they know what's going on. Do you know this person?
Will my colleague be okay?
Okay, maybe she has some pertinent information.
After we finished work, he suddenly started to panic.
Okay, this
Maybe
guy
it's because of
has
their
a clear
divorce.
case of a panic attack or an anxiety attack. He just had a divorce
They
recently.
turned down all offers of help.
This is a completely normal call. We need to shuffle over. All right, get in. And I would normally like to assess vitals while I'm on scene. I would have my partner doing that, or the EMT-B, while I'm initially assessing the patient. However, I have to do it in the box, it's fine. Okay, and let's get some baseline vitals on the patient. We of course want a BP. We don't need to take off the guy's shirt, but that's fine for this game. Normal blood pressure, good to know. Let's get a pulse ox on the opposite arm. Heart rate's at 123. I'd expect that for a
Temperature's
patient
going down. We're back to
experiencing
normal.
this. Let's get a glucose on him while we have the chance. 80, looks good. And while we're here, let's just grab the lung sounds real quick too. Okay. Now, temperature is fine. It's at 98 degrees. I'm okay with that. He's a little bit hypertensive. We can consider administration of lorazepam since we have protocols for that. However, in real life scenario, I would just try to calm the patient and let the hospital decide on this. Let's see. I'm saying this is a psych issue. And panic. That makes sense. Let's see here. Does it say lorazepam? It's a quick sedative used to calm patients experiencing anxiety attack. It's also effective in controlling seizures. Okay. So that's the access, or the, what I have for this patient. Unresponsive? Is it saying my patient is unresponsive right now? Did he vasovagal himself? Then I'm not going to administer lorazepam. Honestly, I'm just going to go. He's still breathing just fine, but I'm not going to administer a sedative to a patient whose GCS is already at a 3. It's crazy. But that's completely normal. For sometimes these patients will panic so much they'll squeeze right where their neck is. They'll cut off the circulation to their blood.
Do something now.
Oh, okay. Use the thermostat.
All right, I'm on it.
If their temperature's dropping. That's cool. I didn't know that you could do that. But I can do some call-outs for changing some things while I'm transporting them. Come on. If their temperature is dropping to that point, then I'm actually okay with going code 3, especially because their mental status, they went from ANO times 4 to a GCS of, what I'm assuming if they're unresponsive is 3, so GCS of 15 to a GCS of 3. It's definitely a good reason to go code. We'll call it a cardiac arrest, or not a cardiac arrest, an altered mental status call. We want to call it a cardiac arrest. Let's see. And I'm guessing they vasovagaled themselves out. And if I was giving a radio report for a patient like this, I'm just going to guess on their vital signs, right? I'm going to say Medic 72 to spawn shoreline. Medic 72, go ahead. Medic 72, I'm coming in code 3 with a, I think it was like a 50 or 35, we'll say 35-year-old male patient. GCS currently is at a 3. GCS was at a 15 on scene. Patient appeared to be in a great amount of stress and panic. Approximately 2 minutes ago, the patient's GCS dropped down to a 3. Current vital signs are as follows. BP is 150/80. Heart rate is at, what was it at? 99 beats per minute. Satting at 100% SpO2. Blood sugar is at 80 and temp is at 95.9. We currently have an IV established in the right forearm, 22 gauge, ETA facility in approximately 1 minute. And this would be a great time to use hot packs on a patient, although we didn't administer it here because we don't have access to it. It is what it is. All we can do is adjust the temperature on the thermostat.
Let me see. We take over from here.
And I wonder if the patient deteriorated because of the slow administration of like lorazepam. I got an S rank, so I'm guessing I did it right there. Let's see. Mute? What do you mean mute? Person? I don't understand how to get some of these readings here. Tight chest, panic. Administer lorazepam, I'm not doing that. And BP went to 151/100. Slightly hypertensive. Temp went from 98.6 to 96. Not ideal, but we are trying to raise the temperature. It's okay. It gave me an S rank, so I'm cool with it. And we're still on shift. We have another call to go to. Come on, Miss Johnson. Oh, you're not Miss Johnson. You're Elijah. I guess we just wait.
Ambulance 152, high priority dispatch, acknowledge, over. Unknown person reported sitting.
Unknown person sitting down in an alleyway. Okay.
Person is reported to be lightly clothed.
Lightly clothed. It could be
Sending
cold
you the
outside
location
depending
now.
on the
Hurry up,
scenario.
over.
but they are unresponsive. They are laying down. We need to go code 3. We always respond to calls code 3. Unless your protocols dictate otherwise, and let's say if it's a mild chief complaint on the phone, sometimes your protocols can allow you to go code 1, just depending on how progressive you are and which city you're in. But as far as my protocols go, I have to go code 3 to every call. And again, if we go code 3, we stay on the left side of the road because we don't want to push traffic into the sidewalk. If I'm actually going for real, I would stop at the stoplight, look left and right, and then go forward. Because whenever we go code, we're requesting the traffic to pull over. However, if we hit anybody, that's completely our fault, regardless of how the other person's driving. Okay. All right. We'll exit the ambulance here. And we'll see if this guy even has a pulse, right? If is this my patient, he's not unresponsive, which is good actually. He's underweight, freezing, homeless. Oh, this is so sad. We need to get him in the box right away. He has a hematoma. Oh, poor guy's shaking.
My left forearm hurts.
Okay. What happened?
My cart.
His cart got stolen. That's so sad. Do you have a blanket or a jacket?
That was all in my cart that got stolen.
That's so sad.
The sun will warm me up.
He thinks the sun will warm him up?
Should I know
We
that?
need to get him in the box immediately.
No money.
This is so sad.
That feels better.
Okay. Can I give some treatments like covering him up right away? No? Okay, we need to get him in the box right away. This guy's hypothermic. You can tell just by his shaking. However, he's homeless. We do have to consider our drugs involved as well. What is the temperature outside? Is it immediately hypothermia? Or are we dealing with somebody who's coming off of a drug and is having withdrawals or is currently on a drug? Okay, let's go ahead and stow the patient inside. And we'll hop in here. This patient, we need to up the temperature right away, right? Okay, what? So I can't figure that out immediately. Okay, but first thing I like to do, let's get a BP on him. Okay, we need to get some baseline vitals, right? We also need a pulse ox on our patient. I wouldn't worry about a glucose yet, but maybe he's shaking because he's hypoglycemic. Temperature is dangerously low. It's at 90.3. We need to increase the temperature immediately. Okay, we're gonna make it dangerously hot in here. Besides that, we need to get a glucometer. Putting it to 91 degrees is insane though, right? Although I don't have any other interventions. Normally I would just keep it at like 76 degrees and put a blanket on him. Okay, I need to assess lung sounds. That's fine. I would like to assess his pupils too, because he is homeless. He's shaking. Maybe this is an opioid withdrawal, or maybe he's on some type of upper or something. We can tell that by assessing that. What is this? Lowers a patient's blood sugar? I'm not administering that. Why is the glucose in orange? It's perfectly fine. I will, however, establish an IV on this patient. And his temperature is rising with the changes in our box, at least for the temperature.
All my belongings in the cart were taken.
The sun will heat me up. Poor guy.
The sun will heat me up.
I didn't know I could re-ask anything to the patient. Okay, I don't see what else I can assess. I need to check a category. What game is this? This is Paramedic Simulator, Moby. So good to see you. Exposure. He has a hematoma. Can I assess the hematoma or no? I'll leave it alone as is. My patient seems stabilized, and I should be good to go. Now, this game is rough initially to play, but I actually think there's some good stuff. Oh, thank you for his glory alone. I really appreciate it. So, you'll see a lot of times temperatures falling. Use the thermostat.
I'm on it.
You see how it offered to administer a placebo medication? That is not appropriate at all. Let's talk about it. So we have a homeless patient, right? A lot of times people are quick to discredit them. They're quick to treat them bad because they may smell bad. You may say, hey, maybe they're on drugs, which is a fair assessment to or a concern to have for a patient like this. But we need to consider what's our patient experiencing. You know, we're not police, so we need to try to help our patient as much as possible. This guy had all of his things stolen, including his jacket. He's freezing, he's shaking. We need to try to increase the temperature on this patient. It's a 35-year-old male patient. But we also need to say, like, hey, I understand that he's shaking and freezing. I want to be as kind as possible. Well, what else could be going on? We need to consider maybe he is hypoglycemic. Maybe he has some type of neuro issue, so we need to check, does he take any past medication? Maybe he got his Keppra stolen and has an impending seizure that's on the way. Maybe he is on an opioid overdose or some type of upper medication that he's currently taking. We want to be very kind to these patients, but we also need to worry about what's going on. And so I think if you go code 3 for a hypothermic patient, that's fine. Looks like his temperature is improving though, so I don't think it's necessary. You see his glucose is indicated as like an alarming feature at 88. I'm not worried about that at all. Between 70 to 110 or 70 to 120, I'm happy with it. And you said, I'm watching this on break at my medic rotation. That's super cool to hear. I'm so happy for you. Just had a crazy peds anaphylaxis we intubated. That's awesome. Be careful saying stuff like that online, though, because we don't want to know what time it is. You have to think about HIPAA. I don't think you're breaking it because you're not specifying anything else, but be really careful. If I ever talk about calls like that, I always make it sound like it's more past tense. Just future food for thought. But congratulations. Good for you. I'm glad you had a crazy call and you got to see how you can deal with something like that. You know, we consider epi administration first for an anaphylaxis call, but if they felt they needed to go that way, I wasn't there. Maybe it was the right move. As long as the patient stayed alive, I mean, that's all that matters.
Let me see.
And we'd cover up this patient, right? We're not going to transport him in his underwear. We're going to transport him covered up with a blanket or a stretcher sheet or something. Really, what else? You think that by going from a glucose of 88 to 80 that I needed to treat him with sugar? I disagree. What did I miss here? I did everything. How could I have gotten such a bad rating? I think that deserved an S too. But we got one S, one A. It's awesome. Even though I didn't assess all that. I'm cool with it. Woo! S and an A? That's good. I'm good with that. I'm becoming a downtown master. Congratulations, paramedic. You have unlocked the drug overdose callout and naloxone or Narcan. Very cool. How do I get to Ammon Heights? Do I have to do the last call here, then I can reach there? I haven't done the training for panic attack either. Should I do the training panic attack? Or should I do regular shift? Good point. I take it back. It was yesterday. That's what I like to hear. Also, it was really late stage. Even with epi, lung sounds were very tight. We'd have lost the airway and had to surgically cric. Then, by all means, if you guys believe that intubation is the way to go right ahead. I've had patients who have gone from, while I'm drawing up epinephrine via IM, or intramuscular, like in the muscle, and as I'm drawing it up, they went from barely being able to talk to us to collapsing on the floor. And even then, IM administration of epi still ended up bringing them back to like a GCS of 3. Going from like talking to me barely to basically unresponsive, but I knew that they got stung by bees, to administration quickly of an epi, bringing them back up to a normal response. But I don't have an issue with what you guys did. I'm just saying perhaps quick administration of epi might have been the way to go, but if they got the tube and they nailed it and they kept that pediatric patient alive, then they're phenomenal medics. It sounds like you're learning from a really great team, so kudos to them. If they're that good where they could establish an ET tube on a pediatric patient like that, then I respect it. I respect it, and I think that they probably did what they had to do. So good for them. All right. The regular shift. We have one last regular shift in downtown. And we also have the training for the panic attack. I say, forget the training panic attack. I already know what they want me to do. The catastrophe or catastrophic event was insane. Let's go for the regular shift. Let's go for the last one. Let's just jump straight into it. Go, 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 go. Am I still with Mr. Davis or am I with Miss Johnson? I miss Miss Johnson now. You know, she was a lot better than I gave her credit for. She's super supportive. This guy doesn't talk.
152, we have
Hey there,
emergency
Tactical
situation.
EMT.
Respond
I think I've seen your
immediately,
name
over.
before. Good to see you.
Person is barely responding to the caller. A person is reported to have collapsed near a club.
Collapsed near a club and is barely responding.
The location is being transmitted to you as we speak. Over.
So what are we thinking? Okay, they're at a club. Maybe it's alcohol intoxication, and maybe they drank way too much and they're potentially losing their own airway. Maybe they are collapsing because they took some type of drugs while they're at a club. So we're thinking opioid overdose. Maybe they took like ecstasy or some other type of like upper, and we need to worry about that. Or it could be a downer, and maybe we need to consider something like Narcan or naloxone as our treatment. For the uppers, all we can do is transport, right? Like rapid transport, and maintain basic vital signs. Maybe they took some unknown medication or drug, and if that's the case, we need to call poison control. They may have gotten to some type of trauma, and which is causing them to collapse. Maybe they drank something or ate something that's at the club that caused a anaphylactic reaction, and that's why they're responding this way. Maybe they're just straight on having like a STEMI. You know, the only way we can assess that is with a 12 lead EKG. So there's so many things that could be going on, but let's figure out from the most critical to the least critical and make sure that this guy doesn't go into cardiac arrest. Maybe he got cut in a fight in the bar or something, is losing blood. Maybe it's an arterial bleed. Let's see. Go, 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 go. Are you... Oh, you're the patient. What has happened here? Uncontrolled movements. Mydresius, rapid movement. Looks confused. I'm going to be honest with you guys. What is mydresius? What is that? Shouldn't I know what everything is? Mydresius? It's dilation, widening of the pupil. Okay. Maybe they're having some type of... Oh, it's eye movements, rapid eye movements. Okay, I read it as widening of the pupil. But I'm not against eye movements as well. Maybe one eye is wide and the other one is small. Maybe they had a traumatic brain injury. Maybe they are on uppers like we initially suspected. Or maybe it's something else. Let's find out. Maybe they have seizure medication and there were bright lights at the club and it caused them to go into like a seize-like state, and now they're kind of coming back from it right now. Okay, what's going on,
Pains
sir?
in the right lower leg.
Pain in the right lower leg. Okay. What's going on
Let's
here?
grab a drink.
Let's grab a drink. Okay, he is altered. What the heck?
I don't know. The night is
Dilation of
still
pupil.
young.
Nice. I don't know. The night is young.
Does Saturday Night Fever count?
Oh, this patient's hilarious.
Only when I party.
Takes medications only when he parties. I think this guy's on an upper. Okay, this guy's not taking it very serious. Did you see him take any drugs?
Just some MDMA.
Just some MDMA. He's on ecstasy. I knew it. As a possible
This never
issue.
happened before. Actually, maybe someone spiked their drink.
Buddy, you just said you take MDMA, okay? Come on.
Just some MDMA, as always.
Okay, maybe the MDMA was stronger than usual. Did you see what happened?
I have no idea, I'm afraid.
Okay, this guy's on drugs. If I see, oh, look. Pills.
They look like MDMA. Probably an overdose.
Oh my gosh. Did we call it, fellas, or did we call it? Classic ecstasy overdose. You know, it's not good to stereotype or to guess what people are doing based off of where they're at and how they appear. But in EMS, sometimes it does help a little bit. In you go. And for uppers, I mean, what can we do? We can give them some saline to try to override. How would you call it? To just help in general. Oh, this guy's temperature could be super high as well, right? Some saline administration can help a little bit. He's really diaphoretic, so I'm expecting his temperature is going to be high too. He's going to be hypothermic. Besides that, though, not much we can do. Okay. We can lower the temperature in the box probably if it's high. Now. It is a little high. I'm not cool with that. Let's see. Let's get a glucose on him too.
Heart rate approaching normal levels.
Okay, blood sugar's at 87. I'm cool
better.
with it.
Let's hope it stays
I'm
that
not
way.
cool with this temperature though. Let's get on the left or the right side here. We'll start an IV on this patient. We'll start a normal saline drip on this patient.
Heart rate approaching normal levels.
Some
Heart rate
people would
approaching normal
consider,
levels.
depending on your protocols, administration of like something like lorazepam. I'm not going to do it because I wouldn't do it in the actual field. Naloxone won't help at all. And if they think I should give normal or naloxone for something like this, they are
Heart rate
bananas.
approaching normal levels.
We also wouldn't administer normal saline this way. Besides that, though, I can see the argument
Temperature's
for
going down.
lorazepam.
We're back to normal.
Temperature's at 98.6. I don't need to mess with the...
Blood pressure is getting too high. We need to do something.
Whoa, why are you freaking out on me? Blood
Heart rate
pressure's
approaching
fine.
normal levels.
I'm not doing
Heart rate
anything for his
approaching
blood
normal
pressure.
levels.
We're going with this. I don't do anything for patients whenever they are reacting this way. I would just transport them to the hospital. 150 over 122. Diastolic's not ideal.
We have to do something now.
Okay, let's adjust the
All
temperature.
right, I'm on it.
Let's increase it a little bit. I don't know, man. I really wouldn't do that. I guess it's fine if his temperature is somewhat falling. His blood pressure is just going to be high, right? But 150 over 123, it doesn't really scare me, but it's something that I'm going to monitor during transport. And if the ER staff wants to treat it or give him like a sedative or something, that's fine. Just something to calm them down. But realistically, all we can do is monitor this patient as they're going through their trip.
Let me see.
Let me see. What have you done? No lorazepam. S rank. They know I'm doing it right. This is a good game. Dual field. What about treatment? Administer lorazepam? I'm not doing it. Blood sugar is at 87. That's perfectly fine for me. Heart rate at 108. I'd expect it. Blood pressure, it says 190 to 126 to 189 over 126. I'm surprised. That is more concerning. Even then, I'm just monitoring them, right? I'm not going to do anything for them. No proper close. How do I assess the no proper close thing? I'm not going to give them O2. They're satting at 100%. And administering lorazepam, again, I can see the argument for it. I'm not giving it for that patient. If you do, I'm cool with it, though. Is there any more 911 calls? I think we've done all the 911 calls in downtown. Oh, yes, there is.
Alarm for ambulance 15. Ambulance
Bring it on.
152, high priority dispatch. Acknowledge, over. Gunshots were reported close
Good.
to a local bar.
Bring on the gunshot patients.
Police have reported gunfire in connection with a gang dispute involving at least one victim. Location sent. Move quickly. Over.
Go, 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 go. And I should have checked the GPS before I started driving to the call. That's okay. One thing though, we're getting real fast when it comes to these calls. Besides the catastrophic event, it's like butter now. Go, go, go. Gunshot patient. First off, when we're going to a gunshot call, what are we thinking, right? Is the scene safe? If not, I'm parking on the street behind the call. And I'm waiting for the scene to be safe. And I'm turning off my sirens when I get close, right? I'm driving. Lights and sirens are code 3 on the left side of the road to not push traffic into the sidewalk. I'm worried about an entrance wound and an exit wound, right? What's the caliber of the gun? Are multiple people involved? Are there multiple patients? If there are, is it the shooter and the victim? They're definitely not going to want to go in the same ambulance. Whoa there, Mr. Taxi. We're just gonna treat it like a video game. We need to worry about, do they have any neck or back pain? Where did they get shot at? Are they currently bleeding with an arterial or a venous bleed? You know, venous bleed, deal with that all day. Arterial bleed, they've only got a couple minutes. Yo, Zeri says, yo, I wanted to say thanks for your NREMT review carrying me before I took the national. Congratulations, buddy. I'm so happy for you. That's what we love to hear. We love helping students. You turn off our thing. Looks like we have multiple patients involved here. So we would definitely want to have a second medic unit en route if we didn't already have that. Looks like that's really important. We have the caliber of the gun. Okay, what's going on here? Patient is losing blood. Fast breathing. Hyperpnea. Okay, is this an arterial bleed? Strong bleeding? What's going on?
Chest, stomach. I'm just in a lot of pain.
I believe it, miss.
I'm not feeling good, but it seems there's a guy worse off than me.
You're a hero for that, for saying that, by the way.
Blur. It all hurts. I haven't had any chronic illnesses.
Normally, we wouldn't be asking all these questions, by the way. We'd be done with her.
No, I haven't taken any medicine.
I want to throw a tourniquet on you and move.
That feels better.
Great. Okay, let's throw a tourniquet. This leg right here on the right leg, because I can see blood literally spurting from your pants. It's crazy. What's going on with you? Patient is losing blood, coughing, hematoma, crackling sounds, bloody hands, bloodstream. What the heck? Okay, I can kind of see it. Looks like there's losing blood on the left arm. Let's go ahead and throw a tourniquet on there. No proper clothes. Okay, good to know. I can't see what's going on the left leg.
It hurts to the core of my body.
I believe you, buddy.
I have a really dark bruise.
He's coughing up blood. He's red.
No chronic problems.
We need to consider possible, see if there's an entrance and exit wound on his chest and his back. And we may need to do a needle decompression.
Starting to feel better.
Depending on his lung sounds, right? Can I see his back? No. Okay, you're getting triaged as a red. Miss, you're getting triage as a red also. Sir, you're coming with me. You are having a hemorrhagic emergency. Venous bleed, I'm cool with that. You are having a hemorrhagic emergency as well. And it says that this is a venous bleed. That's fine. I'm cool with that. Go, 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 go. Normally, we'd wait for an engine to show up on scene or an additional medic unit. And they have to be a paramedic. Or they have to have a paramedic on one or the other. And then I can leave one of the either engine or the second ambulance with the other patient. And preferably I leave with the less critical patient. So I'd actually leave with the female patient. I just prepare him for transport. Is there a case where you take both in your ambulance? If they're both related to each other or family friends, I personally have enough experience where I would be comfortable taking both in the ambulance. However, what if one of them shot the other one? I don't know that, but if that was the case, then I don't want to take both patients in the same ambulance because, of course, they're going to hate each other, right? But if they're both victims, I would be okay with taking both people in my ambulance and just get going immediately, right? They're both going to go to the same spot, a trauma facility, just check vital signs. They're both, in my head, fairly stable with the bleeding. He is in a much worse state, so he's going to be the one on the stretcher. She's going to be sitting on or be laying down on a backboard with the C-collar on my bench. He's going to be on a backboard and C-collar on my stretcher. And I can make this work, honestly. I've dealt with things like this in the past, and I'm on the mindset of just load them both up. However, your protocols may say just take one patient. That's fine. I normally wouldn't leave this patient here like this. I think it's inappropriate to do so. That person might be PD, and they may have some more information, or maybe I can see if you want to try to leave them with them, but they're not paramedics, and technically this would be abandonment. No, I need to ask you a question. What happened?
Looks like a typical gunfire exchange between two local gangs to me.
Okay, worthless. Yeah, but we need to have a paramedic on scene if we're leaving the scene. Can you tell me what happened?
One of them got hurt pretty badly. You should probably hurry.
Yeah, it's the guy. But this would be abandonment right now. Okay, let's assess some vital signs on this patient. And it looks like the left arm's the affected side. So let's go ahead and establish vital signs on the right arm. Let's get a pulse ox on the patient. Normally I'd want to do this on the scene, but it's okay for right now. It says hypertension. I disagree, but it depends on your protocols. I can't see what's going on here. Unfortunately, they don't just let me remove this or the clothes on the patient. I wouldn't normally bandage this wound. Being able to visibly see it more as just a bruise or a hematoma. Okay, perfect. Let's throw on a bandage on the patient.
Blood pressure is getting too high.
Okay, calm down, buddy.
Temperature is going back up to normal levels.
Let's go ahead and bandage this area. Even though we have a tourniquet, I'm not against bandaging up a wound like this, especially if it's still rolling with bleeding. Maybe the tourniquet's not on tight enough, which is a common issue that providers may have, depending on your level of training. A tourniquet hurts a lot more than a lot of people initially think. Okay, we'll establish an IV on this patient. Beautiful. Oh my gosh, perfect. I miss IVs quite often. So it's nice hitting them all here. I'm okay. I don't need to administer medication at this time. If he was complaining of pain, I would consider to do so, but I'm unable to really assess it here. He's freezing. Poor guy. Okay, if he's freezing, we need to do something for his temperature. Right, he's going into shock. I can still give him some saline, but he's coughing up blood, so I wouldn't do that. I don't have access to needle decompressions, but I don't really know if that would even be necessary. Actually, this is making his temperature worse, even though he's freezing. I need to assess his lung sounds is what I need to do. Let's keep him at 81 degrees. And then, as far as his lung sounds, let's see what's going on. I'm sure it's not good. Okay. He's shaking up a storm.
Don't delay transport.
But
Let's
I
go.
agree, let's go. Let's get out of here. He's coughing up blood. I'm going code 3 for a call like this. This is a serious trauma. He may have a cracked or fractured rib.
Too low.
Temperature is dropping rapidly. Use the
Understood.
thermostat,
I'll
but
handle it.
his temperature is at 99.2. I think you're being ridiculous. I don't know if that's actual accurate vital signs on a patient. Go, 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 go. Normally, I would just turn off the AC. I wouldn't personally raise the temperature in any way, but turning off the AC will be enough to heat up a patient appropriately. And then I'm going to use hot packs, and then I'll also cover up the patient using something like a blanket. It's not an option in this game, or at the very least, use some stretcher sheets and just apply them over the patient in general. If they have their clothes, even though we took them off, which I don't think was necessary to get a BP on them, but we do want to assess everything. So maybe it actually is. We need to potentially at least drape his clothes back over him to maintain some of that temperature on him. And I would go code 3 for a call like this. Definitely. Beautiful. Let's wheel him in.
Let me see.
What are you thinking?
From here.
They have him on a backboard. That's nice. A B. Triage score minus 50. Wrong life-saving intervention? What do you mean? Treatment. Treatment. Inspect for bleeding and apply bandages if needed. Monitor vital signs, especially blood pressure. Blood pressure was 114/76. I'm perfectly fine with that. Yeah, their blood pressure is 148 over... I disagree with this game. 148/99, you're going to say a B. Temperature is at 94.5. His temperature was at 98.9, 99 the entire time I had him. It's just inaccurate. Some issues with the game. But that's okay, right? We're not going to hold it against them. I'm going to give both of mine an S. At least the rationale is there. Beautiful. GTA 6 should be shaking right now. How do I unlock District 7? Or I'm on Heights. Do I just need to play more scenarios? I've unlocked amphetamine influenced, amphetamine overdosed, naloxone, opioid overdosed, okay. 148 is a bit high. You're right in a sense. Depending on what you're reading, some would call it stage 1 hypertension, stage 2 hypertension. However, what are we going to do for a patient like that, right? That's bleeding arterially, or not arterially. If he's bleeding, you know what? We could have considered pain management. We could have administered medication like morphine. Xerxes, I'm kind of doing it randomly at this time. So I agree with you, Felix. I actually didn't administer pain management. Maybe I got too tunnel visioned on the coughing up blood and the leg plus the shivering. So you were worried about possible respiratory depression at that point. But I think if I had something that wouldn't knock out his respiratory system, maybe like acetaminophen, I could have considered it. Actually, no, because I don't even know if I'd administer acetaminophen. I don't ever administer it for pain management. in the field, but some places do. I know GI bleeds are considered a contraindication. I wonder if you consider it for an upper respiratory bleed as well. No, I don't think I'd administer any pain management. I would just monitor him. But yeah, I could see the concern of that. But yeah, I just go live randomly if I do go live. I'm actually considering chopping this up and putting it in some YouTube videos later. But I thought it'd be fun to do live too to see what some of you guys think. Okay. Now the question is, do we do one more call or do we call it here? We've hit up a lot of scenarios as is. We can do one more. And if we do one more, do we do the regular shift or the panic attack? I think we can do one more. I think I got one more in me. I'd like to see their protocols on this, though. One more call. One more call. One more call. It looks like once I reach level 7, I unlock Ammon Heights. Which sounds interesting. Let's just go straight for. Let's just go for a regular shift. I refuse to do the training for panic attack. But that's cool that you're referencing, Felix, German standards. I went to Germany once in person, and it was the most beautiful country I've ever visited in my life. I love America, of course, but I truly did love visiting Germany. That's something I need to take my daughter to one day.
We have a residential building reported burning.
Incredibly beautiful. Residential burning.
There might be more than one person in the building. Be prepared for smoke inhalation and burn victims.
Okay, we have smoke inhalation, burn
Transmitting
victims.
the location now. Hurry up. Over.
Residential structure fire. Who knows how many patients we have? It's kind of a mix because of the publisher development team, so it's confusing for me myself. Yeah, who knows, right? One more. Oh, hey! Vitali Renicus. I truly appreciate your support, by the way, Vitali. It's very kind of you. And I agree, one more it is. Now, again, if you're heading to a call, as long as it's not like European where you travel on the right side versus left side, I can't really tell you. We're going to stay on the left side of the road when we go code 3. We want to push all the vehicles to the right lane. We don't want to push them onto the sidewalk. And normally if we're actually driving to a call, you know, we want to make sure that we're going max, depending on your protocols, like 10 miles over the speed limit. If you see a stoplight, we're looking to our left or right. We're kind of slowing down or stopping and then going, right? This is a video game, so I'm just going to kind of drive however. But something to keep in mind. Right, see, I lost my license. Hitting that person right there, you lose your license. But in the game, it's fine. Beautiful. And we thread the needle? Beautiful. Sometimes it gets a little sketchy like that. Sometimes, if you get in bad enough traffic, you need to just turn off your lights and not panic people and just wait for traffic to clear up a bit, because you're just causing a disservice. Yeah, exactly. Pedestrians' faults. Even though it wouldn't work like that in an actual call. Okay. Not an ideal spot to park, but this is fine. And let's see what's going on. We'll start with this patient.
Chest, stomach. I'm just in a lot
Chest,
of pain.
stomach, I'm in a lot of pain. How can I be of assistance? That's a crazy thing to ask. Having trouble breathing.
Trouble breathing.
We're thinking smoke inhalation. We need to consider
Breathed in too much
RSI
smoke.
on this patient. We need to consider establishing an advanced
I had
airway.
an incense stick burning, but I doubt it caused the fire.
Okay, I understand.
I ran out of the building as soon as I saw the fire.
Okay. I'm not going to say unusual scene. Usually the guy just says, oh, you left without saving anyone? How could you? I'm not going to say that to a patient. That's for crazy people.
I don't think modern medicine is...
You don't believe in modern medicine? You're about to get a lot of modern medicine right now.
I'm starting to feel better.
But this is a patient where you may need to ask Are you okay with me administering X amount of medications, right? You need to get patient, what is it called? Smoke inhalation, difficulty breathing. You can't assault a patient or batter a patient or commit battery by administering something they don't want. Okay, what about you? What's going on here? Do you know this person?
Yeah, I live right across the street. It looks like they've gotten worse.
Okay.
They were all
I
standing
know
at the
in real
beginning.
life I'm done talking to this patient already, but I think this game wants me to
What
assess
a
some of it.
nightmare. Everyone had already escaped the building by the time I arrived.
Move out of the way. You're a cop, you're fine. Oh, I need to triage this patient too. Okay, triage, you're getting a red tag. You're about to decompensate. What about you? What's
Pains in
going
the
on?
right
You're
lower
coughing and
leg.
losing blood?
My skin feels like it's on
Skin
fire.
feels like it's on fire. Don't cough
I'm not
all
certain
blood on
how
me,
the
please.
fire started.
He could have
Well, but it's not
tuberculosis and we
flames.
just don't know.
I
Although the
think he was searching for
mechanism,
other people in the building.
it basically advises you that it's not that.
I need help.
We'll
no
go to you
issues
soon.
that I know of. Nothing prescribed. Just some headache pills.
Okay, okay,
This way.
That feels better.
okay. Assess real quick. Boom, boom. Underweight. I'm not saying the unusual scene. Strong bleeding on the left arm. That's good to know. Okay, you need some treatment initially. You need a tourniquet on this arm. Okay, and you know what? Can I put it?
Over here.
I don't need a tourniquet there. I can't tell what's going on there, but it won't let me further assess. We're just leaving you alone. Did I triage him? I didn't triage him. Normally I wouldn't go back to triage this guy. I'm going to put you as red also because you have a critical life bleed. Okay, what's going on with you? Strong bleeding on the left arm. Multiple burns noticed on the leg. Okay, we need to treat the arm before we even talk to him. Supply a tourniquet. And then it looks like they have a burn there too. Let's talk to the
Right
patient.
upper leg's hurting.
Right upper leg's hurting? I believe you.
My skin feels like it's still burning.
Skin feels like it's still burning. I can see that you have a possible
I'm not
stage 2 or
sure
stage 3
how the
burn on your
fire
right
started,
forearm.
But when I saw the flames, I checked to see if anyone else was in the building.
Okay.
I haven't had any chronic illnesses. No, I haven't taken any medicine.
If you have strong bleeding from the left arm, you're getting a red also.
I'm starting to feel better.
Okay. Triage, you're getting a red. I think this is all the patients. We're going to go for the person who had a respiratory emergency. We can do the interim, that's fine. I don't know any of their names. What's your name? Boris? Boris, you get a hemorrhagic emergency. You get venous bleeding. Lan Choi, hemorrhagic emergency, that's fine. Are you the one with the respiratory? Yes, you are. Smoke inhalation. I'm going to transport... Okay, I've mentioned this a bunch of times. If I had incoming units, we need 2 more medic units, right? I would say medic 72 to fire dispatch. Go ahead and dispatch an additional 2 medic units. I would also say, and I would talk to command about this too. And I would say medic 72 to all incoming units. We currently have 3 red tag patients, level 2, at this time. And just leave radio traffic kind of at a minimal, but let them know they're all critical patients. Level 2 means critical where I'm at, but it could be different from where you're at. If you use the start triage system, just saying that they're red tagged is fine as well. And then we can focus on the most critical patient. The only thing is, that woman is the most critical patient. When the second medic unit arrives on scene, I would set it up so they transport her. We are the last ones to leave, and we will transport probably that female or that one female that was the third patient. Either her or the guy, it's fine. But we are worried about smoke inhalation. If there's a paramedic in the engine, there is a chance where we may kind of bypass what we would normally do for triaging and say, hey, you stay with the other two patients. This patient's a smoke inhalation patient. They need to be immediately transported. And as long as they have a paramedic on scene, it's not abandonment, and we can take them. Okay. Miss, I need to assess some baseline vitals on you. But we need to consider management of her airway immediately. It would actually be okay to assess her SpO2 first before we assess. Let's see here. It would be okay to assess her SpO2 before we assess her blood pressure because of the severity of the burns, right? I could check. I would not check a blood glucose on her for real. Not till later. Okay, we need an IV on this patient. She's sitting at 100% right now. That's not going to be the case. We need to RSI this patient or do rapid sequence intubation. Although in this game, I don't know if I can just RSI them right away. Can I do RSI on a patient? I'm just going to say I RSI'd her. This is crazy to just do for a patient. If we haven't RSI'd the patient, they're going to gag and puke, right? This is crazy. You would not do this in real life. You would RSI. You would administer etomidate or something, succinylcholine. Shoot, she's breathing. That's crazy. Can I remove that? Take it off. Take it off of her. You don't RSI. We've killed this patient. She would be puking. This is a nightmare. I didn't know. Full disclosure, I thought that they would consider doing an RSI or at least show it. Establishing an endotracheal tube on this patient immediately is
Temperature keeps falling.
insanity.
Now.
Blood pressure keeps falling. Temperature is dangerously low. Okay, use the thermostat then.
I'm on it.
I see. We would not just put an ET tube on a patient just because. That is complete insanity. Full disclosure, I thought that they would do an RSI kind of thing or something, or fake sedate her and then paralyze her. This is crazy. So you would do something like etomidate, then succinylcholine or something, or roconium, depending on your protocols. Then you would do something like midazolam or some other type of sedative mixed with that paralytic, because etomidate only lasts so long. I'm just saying this game didn't, don't shoot the messenger. But just establishing an endotracheal intubation on a patient while they're conscious and still breathing, crazy. We want to establish an advanced airway, but not if the patient's conscious, right? You are, no matter what, no matter if they have smoke inhalation. So just to preference it. If you need to add an option to toggle siren and lights separately, I wouldn't stop in traffic without lights. Well, you're describing kind of like what's called code 2. He says S, I say F rank, by the way. Wrong life-saving intervention. That's an F rank. Anyway, you can't go code 2 ever whenever you're showing up to a call. You always have to go code 3, so you need to go lights and sirens, Felix. You can't just do lights or sirens. However, if you're showing up to the call, it would be okay to leave your lights on as you're parked and have that on during the call. Also, we should have gone code 3 with the transport. No, at the scene. Okay, then I agree with you completely. Yeah, you would leave your lights on while you're parked in traffic. I completely agree with you. As a paramedic, are you usually doing these procedures on your own? Or do you have a medic? It depends on the scene that you're arriving at and depending on the type of transport that you have. So a lot of times you'll be a paramedic with an EMT-B on your box unless your agency is all medics. without any EMTBs, but I respond all the time with an EMT-B partner or an AEMT. It just depends on the level of their skill set. But at the very least, they can establish vital signs. If your protocols allow it, EMTBs can even establish IVs. They can establish EKGs. But national-wise, an AEMT and above is what can establish an IV and establish an EKG on the patient. But yeah, I would kind of have to do it on my own, depending on the protocols. Or at least for any of the difficult procedures like the intubation. But I would never intubate somebody who has smoke inhalation but is still conscious. I mean, that's crazy. I said wrong intervention. I mean, clearly that was a wrong intervention.
Ambulance
They don't
152, we
RSI.
have an urgent situation.
But whatever,
immediately
you
over.
figure it out in the game, I guess.
Person is barely responding to the caller. An unknown person is reported to have collapsed in an alley. The location is being transmitted to you as we speak. Over.
I think we would use a larynx mask, not an ET, because we've only cleared for that, except you're a physician. If you're a physician. So what do you mean, like a larynx mask, like some type of supraglottic airway? And then, honestly, we would just monitor their airway if we don't have RSI protocols. Anyway, let me read some of these real quick. That must be wild. Inserting an IV and intubating a patient is harder than supraglottic. Then you can consider supraglottic, but only if the patient has an altered mental status. If they're unconscious. Otherwise, if they have a gag reflex, you're not even going to do that. So realistically, intubating that patient or putting an LMA or a supraglottic airway, or as you said, a larynx mask, would just be a bad idea. So that was kind of a mistake on my part. I thought they would RSI her, but they didn't. That must be wild. NPA max. I agree with you, Felix. NPA and BVM. But honestly, her SpO2 is fine breathing on her own. Why not just leave it alone as is, right? Why even irritate the airway? So that must be wild. Inserting an IV and intubating people, is it harder than it looks? Or would you say it's easier? IV, not really too difficult. Intubations, they can be tricky. Depending on your patient, you don't have as much setup. And if you're the only medic, then it can actually be fairly difficult. Establishing it on a patient, if you miss an airway, then just throw in a supraglottic airway. It's difficult, but I always say go for it. And the worst case scenario, at least throw in a supraglottic airway. But ET tube should always be attempted first, unless specific conditions or variables say otherwise. Firefighter says, "Hey Mario, I passed my NREMT for the first 2 weeks. Shut off at 64 questions. Just want to say thank you. Your test prep bundle on amateur medicine and accompanying video were tremendously helpful. Thank you very much, Firefighter. I agree. At amateurmedicine.com, we have a great test prep study bundle, and I'm glad that I could assist you on studying for and preparing for the National Registry. I'm so glad you passed, Firefighter. Way to go. I can't wait for you to go for medic next." And Zijuan Wu 4930, "I have my NREMT exam tomorrow. I did 1K questions on Pocket Prep, and I'm watching your videos. I have a good chance at passing, right?" Yeah, I would say so. I think you have a great chance. I sell a test prep on my website at amateurmedicine.com. But if your your NREMT is tomorrow, I wouldn't bother purchasing something like that at that point. You're already so locked in with Pocket Prep. Just learn what's right and learn what's wrong, and then go from there. And do an honest effort. And if you fail, you said you did 1K questions. That's a ton of questions. I would argue, are you doing them too quickly? Do you slow down and do you look up why an answer is right or wrong? Sometimes students, they'll do all the practice questions all in 1 day or 2 days. And it's like, well, what did you learn from it, right? So we may need to break that down more. But I hope you do well, Zadrun. And we have a Discord channel in all of our video descriptions. You can always hop in and ask further questions. I'm cool with that. But let's see. Let's get over here. Okay, so we have a person who was found unconscious, laying down in an alley. What are we thinking? Okay, if they're laying down in an alleyway, they might not be the best of character people. We don't know. But right off the back, we're assuming an opioid overdose. If not, maybe some type of drug overdose. It could be maybe they went to the alleyway while they were jogging. They're hyperthermic. Maybe they're hypothermic if it's cold outside. Oh, PD's on scene. It's good. And, you know, worst case scenario, maybe they were walking and they suddenly felt kind of weak, so they went to the alleyway. Maybe they're having like a STEMI or heart attack. What's going on?
I don't know them that well, unfortunately.
That is unfortunate. I need you to move. What about you? Do you know them?
I don't know them that well,
All right,
unfortunately.
I need you to get out of my way. Oh, it's 2 patients. Wow. Look, we have a lot of drug use here. We have needles of the drug paraphernalia. It's very sad. Underweight hematoma. Reduced air hunger. Okay, so they're just not breathing as well. Meiosis. Okay, red bumps. What about you? You look... Are you dead? Why can't I assess you? Okay, what's going on? I don't care about you. Can I talk to you? Can I talk to you? Hello? Okay. I think it's an opioid overdose. You know what? Maybe I can't ask them any questions because they're unresponsive. Zeri says, I was in your exact same boat a few months ago. I got cut off, but I failed. But now I ended up passing. Yeah, I get you. I used to use Pocket Prep whenever I was a student. I don't have any qualms against it, but I felt like I had issues learning with it. That's why I created my test prep. But I'm not against students using it. You know, I just make honest effort. Okay, so we can't ask this patient questions because they are suffering from a possible opioid overdose as suggested. You want to be really careful when inspecting the patient. You don't know if you're going to possibly get stuck by them, so be really careful around their pockets and around their temperament in general. I do want to assess a BP on them. They have some bruised up skin. You have to be really careful about possible infection. They may have something that if you touch it, it can transfer over to your skin as well. We really care about their pulse ox, about what their SpO2 is like. Maybe they're having respiratory depression. We need to establish an IV on this patient. And again, be really careful when you're handling this patient. You don't know if their skin contains anything that you don't really want to be interacting with, but they still need an IV regardless, right? We still need to consider managing their airway or their response with naloxone. Where's it at? Okay. And we administer this intranasally, that's fine. This is an interesting place if they, let's see here, no proper clothes. If they carry naloxone that way instead of you drawing it up. Normally you would have to draw it up. Anything else that I'm seeing here? I do want to assess their lung sounds. And you know what? They were unresponsive earlier. Maybe we need to check out if they're hypoglycemic. Right, they may not be eating properly, depending on their initial presentation. Blood glucose is at 77. I'm not a fan of that. But also, what route do I have for their blood sugar if I wanted to maintain it? It's still within the normal range, but it's something I'm going to pay attention to. Some agencies will say that's too low as is. I'll administer some saline to this patient. I would do a 500, 1,000 cc bag or milliliter bag. I wouldn't just push it with a needle into the patient, but that's fine. Should help improve somewhat. I'm not a big fan of their temperature being at 99.4, but it's not enough for me to do any interventions until it's 100.5 or greater. I wonder, can I talk to the patient now? Get me back in there. Can I talk to you? Not yet. It's fine. I already administered some saline, or I'm administering saline to the patient, so they should be fine as is. That patient that I'm leaving behind, though, disaster. That patient looks messed up and looked like he even needed to be transported as well, so we would normally call for backup. We can't in this game, though, so we'll just have to leave him as is. I wouldn't go code 3, I would go code 1 for a patient like this.
We have to do something now.
Temperature is dangerously low.
Understood. I'll handle it.
I'm really confused on how you administer medications in half of the games. Isn't there a port you can insert on the back of the IV?
Patient doesn't like that at all.
Yeah, so normally we would do like a saline lock with our patient, and we would administer it via that. We wouldn't go straight through the IV catheter port, right? We need a saline lock on the patient. I'm pretty sure that's what you're discussing or talking about, Felix. And we would administer a saline drip to the patient. We wouldn't be pushing it. Core temperature is rising. Use a thermostat.
Understood. I'll handle it.
It's fine. And normally we wouldn't be driving like this. We'd be driving slow through traffic. But because this is a video game, I'm just going to drive like this. It's fine.
Our patient doesn't like that at all.
Yeah, but this game doesn't do a good representation of how medication should be administered. That's one of the falling points of it. But you know, there's highs and lows to every game. Really, the criminal thing here is neglecting that one patient that was next to him sitting down. He needed to go to the hospital too. An administer of naloxone or Narcan to a patient, we'd want to worry about them waking up and being violent, possibly puking because we've ruined their high. So your partner may be in a dangerous situation.
Let me see. We take over from here.
You said, yeah, saline lock, but with the 2 ports. You're talking about like a stopcock. We wouldn't need to utilize a stopcock for a patient like this. What is it called? A saline lock on a patient would be just fine. The 3-port, I don't believe would be necessary. That's more so if you're considering administration of something like adenosine, depending on what you have set up for your medic unit. Oh, you got a nest. That's good. Let's see. Treatment. We administer saline. Utilize the ventilator. Not necessary at all. And I'm happy with everything here. That's fine with me. But good question, though, Felix. Beautiful. Goodness, we've done it. Okay. So, fellas, my sweet daughter is going to be out of camp. And afterwards, I'm planning on taking her to go do a written test to see where her English skills are at. And then we're going to prep her early for middle school. So I'm so excited for her. She's going to do some summer classes because I'm kind of that. I think my mom described it as a Karen Tiger or something. I'm really staying on top of my daughter's education. Thank you all so much for participating and joining today. I really appreciated it. But I'm going to be heading out now. If you're struggling with the EMT-B, you can check out our website on amateurmedicine.com where we provide test preps for the EMT-B and the AEMT. Thank you guys very much, Llama and Felix. If you have any other questions, though, you can join us in Discord. Let's see here. How do I invite to channel? You can always join us on Discord, and we'd love to have you and love to have any discussion or any questions that you have. We'd like to answer them, and if you bring anything to the table, you know, we have somebody who goes in there and he tutors sometimes. He does a really good job, and we have a lot of knowledgeable providers in there as is. But with that being said, thank you guys so much for joining in, and I hope you have a good one. Take care. Good luck with your daughter. Oh, thank you. She's a sweetheart. If anything, pray for her because she's getting out of camp to do an educational thing. I can be a tough dad sometimes, but I try to be sweet to her. She's a good kid. All right, you guys have a good day. Thanks for joining in. See ya.